Okay, welcome to today's meeting of the Health and Social Care Select Committee at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners and adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm chair of this committee. Before we start, I have some important housekeeping for everyone present. Please ensure that any mobile phones are on silent. We're not expecting a fire drill, so if the fire alarm does go off, please follow Nikki out of the building. Please keep your microphones muted when you aren't speaking and then unmute to speak. As chair, I will call on those to speak during the meeting. It's worth noting that some of the councillors on this committee may be using devices to access agendas and papers for the meeting. So we'll now move on to the agenda. Do we have any apologies for absence?
Chair, we've had no apologies for absence, but Councillor Nelson has advised that she's running a little late.
Okay, fine. That's fine. Do we have any declarations of interest before this meeting? No? Oh, yes, Councillor Martin.
Yes, it just needs declared employment at Harefield Hospital.
Thank you. The minutes of the meeting on 25th of March, are we happy with them or do we have any comments? Are we all happy? Are they all agreed? Fantastic. Everything is in public? Part one, so fantastic. Okay, so we move on to item 5, which are health updates. And so we have a really big cast of local health providers here again, so that's really fantastic, so thank you so much. So what I'm going to do is I'm going to go through them in an order that makes sense to me, but please feel free to jump in if people come across or say something which is relevant to their area, so obviously because we're all obviously joined up and work across each other's areas. So first of all, I wanted to start with Lisa Taylor, Managing Director of Healthwatch Hillingdon. Lisa, can you give us an update on what you're working on at the moment?
All right. Can you all hear me? Is that better? Yeah. Excellent. Okay. Evening, everybody. Hope everyone's enjoyed the sunshine today. So just a few updates, just verbal updates on what we've been doing. So our focus really has been on completing some projects that we started last year, mainly focused on GP access, children and young people's mental health, and also reviewing the Pharmacy First scheme and seeing how well that's being utilised in Hillingdon at the moment. With regards to children and young people's mental health, I gave a presentation yesterday at a Hillingdon-led Thrive event for professionals to report on the work that we've been doing and make some recommendations for improvements. We've engaged around 500 children and young people in Hillingdon now and their families to find out what their experiences are of using mental health services in Hillingdon, what their needs are, what the barriers are to accessing support, and what they need for the future. So the aim being to develop a model of mental health services with no wrong front door. We focused on children and young people that we identified would be at the highest risk of health inequalities and discrimination. So we did some targeted work with looked after children, children with autism, young people who identify as LGBTQ+, children and young people from black and minority ethnic backgrounds, and also young men involved in the youth justice system who often present with undiagnosed mental health conditions, learning difficulties, and delayed speech and language. So our final report will contain some key recommendations and a roadmap to improvement. We've been successful, I think, in having some influence locally. I know that we've been working very closely with Kim Rice to look at where improvements could be made around access within primary care. We've been very involved in the development of some of the family hubs in the borough and a 0 to 19 directory of services, not just for children and young people and their families, but also for professionals to support them to be able to signpost better and find more appropriate support for children and young people when they need it. We've also worked very closely with voluntary sector partners to understand the challenges across the system. So there's some recommendations in there about voluntary sector sustainability as well, and embedding them into mental health pathways. So I will share that report once it's finalised, as I think it would be useful in terms of revisiting the committee's work previously on mental health pathways for children and young people.
Lisa, sorry to interrupt you there, but you are right, because we did a report a while back, which, Vanessa, you engaged with, and work is happening due to that report. But what I think would be super useful is when you finish your report, once it's sent to us and we've had a read of it, maybe then we can plan a sort of longer session on what's going on as well, because, obviously that would be really interesting. So,
great.
Thank you.
GP access. We sort of put hold on our work because North West London ICB did a bigger piece of work looking at same-day access in primary care. So we've sort of adapted our work to look at more targeted groups. So people experiencing homelessness, asylum seekers and refugees, the traveller community. So we're working on that at the moment. Also working with Carers Trust to make sure Carers View is part of that as well. So again, that will be another report that I will share with the committee once it's done, and similarly with the Pharmacy First review. Key sort of issues that we're still picking up on with regards to GP access is digital appointment systems, not just around digital exclusion, but also the availability of them and the usability of them. Long waits on the phone is still an issue in some areas. There's confusion now about lots of multiple apps across a number of health services, which is people are finding difficult to navigate now. So something for us around making recommendations, that consolidating apps. Still some concerns about the continuity of GPs, particularly for those with long-term conditions or complex needs, and barriers for residents who don't speak English. What we're currently hearing about, and I'm really sort of happy to be able to raise this today, is the closure of the minor injuries unit at Mount Vernon. So a couple of weeks ago we had residents contact us, and a couple of my board members had people turning up at their doors because they'd heard that the minor injuries unit was closing. We've been advised that no decision has been made about this. However, I've been informed that staff consultation is happening at the moment, so I would like to have some information, if anyone's got any this evening, around what's happening, what a closure would mean for residents, and if there's likely to be any detrimental impact on services.
So I think to be a dynamic meeting, I think rather than coming on to this later, which it certainly would have come up with later, because we've also picked up some sort of queries about this. Leslie Watts, Chief Executive of the Hillingdon Hospital Trust and Chelsea and Westminster Trust. Would you like to speak to this matter, and then we can have questions on this matter, then we can go back to other matters? Is that okay?
While I'm here, I don't know if you've all met Alan McGlennon, who's the Chief Medical Officer at the Trust and also the newly appointed Managing Director of the Trust. So thank you. So let me just say a bit, and I'm pretty sure, I know Doctor as well, he may well have something to say. Let me just put a little bit of context. Let me just be clear. But there is no consultation happening at the moment with staff. Let me just be very clear about that. And no decision has been made about the closure of the minor injuries unit either. However, let me just say, let me be as transparent about this as I possibly can. Which is, so there is no secret to anybody in this room that Hillingdon Hospital exited last financial year with a deficit of £27 million. It has gone into this financial year and it has a balanced plan, but that plan is balanced because we have £34 million of, it's called unearned income, if you like, but it's discretionary income that's coming into the trust. And so it is absolutely clear that we're going to have to work very hard to think about how we make the services for the residents of Hillingdon as sustainable and resilient as we possibly can, and actually how we get the new hospital built. And I think I did say that last time, actually. So I think there is something that says, because of that, we will look at every single service that we're looking that we provide and make sure that we're doing that in a productive way. The second thing that I would say is, if you look at so one of the reasons that you would look at services on both sides, but particularly around the minor injury service at Mount Vernon is, if you compare what's happening in our main hospital and the wait for our sickest patients in the main hospital not acceptable. It absolutely is not acceptable. And so there is something that says you have to have a look at how we provide those services in terms of the quality of care we provide, the operational performance, the resilience of staff actually, and then how you do that in the most productive way, and you ensure that there's an equality of the service that you give, is in a nutshell what we will be looking at. Now we have, there is definitely a discussion about the minor injuries unit. We will engage, not in this meeting, but we will engage with Health Watch, with our local authority colleagues, and of course we will engage with the staff concerned, but we need to make sure that we're ready to do that and to have the evidence that you're going to ask for, the facts, before we do that. And I don't know if there's anything you wanted to add to that.
Yeah, I'll just say a little bit, which is, the numbers are enormous. A lot of the deficit can be ameliorated by working extraordinarily efficiently with what we're doing. However, there will still be a chunk of money that we will not be able to live within our means. So we have been encouraged all the way up from the Secretary of State to make sure that we look at our models of care and make sure they're appropriate. I want to be extraordinarily clear. All of the ideas of anything that we should do differently for our Hillingdon Hospital comes from the people running the services. We by and large are residents of the borough, which so am I. In fact, I live very near the minor injuries unit. All of the plans that have come to us, and we're not going to do all of them, we've been very clear, the quality of care cannot be reduced. The patient experience globally cannot be reduced. However, we have healthcare inequalities throughout the borough, and we must tack towards improving those. And I'm encouraging everybody to think laterally, which is, have we got the correct models of care and distributed our resources entirely properly? And that's not directed solely at the minor injuries unit. It's directed at all of our care. If you look at the three aspects of Hillingdon Hospital, we are an urgent care provider, and we've been suffering with quality, with performance, and with experience for a good number of years. We do very well with our planned care, surgery and appointments, and we do quite well actually for the NHS for our cancer treatment. So it's clear that we look at our urgent care first, because that needs to be attended to. So, but I would like to double underline, absolutely no decision has been made.
But an agreement that we're looking at it. So just to be very transparent, we are definitely looking at it.
So can I just to clarify then for residents that yes, all services are being reviewed at the moment, but actually absolutely no decisions are being taken as yet.
Correct.
Okay, thank you.
Thank you. Just on this point, I know Philip, Councillor Corfield, I need to get my head into this meeting space. Councillor Corfield, I know you. This is of particular interest to you, so I wondered, do you want to ask a question on this matter, or?
Yes, I may.
Yeah, go.
I suppose we're all grown up in this room. We know that we sometimes have to face into difficult decision making around service provision. We all get that. If I'm honest, I'm disappointed that much of what we've heard around this was very much on social media to begin with. Let's remember, of course, that this is a committee which has a statutory function to scrutinise health providers and the provision of services. So that was disappointing, frankly. I'm encouraged to an extent that there's going to be a measure of consultation. It would be interesting to know a little bit more about that, how that will work. Yeah. And also, how does this fit within the neighbourhood working plan that we've been hearing about? We had a visitors hub in Ruislip the other day, because it's important to us that we are focused on service delivery for our residents, and we've been caught blindsided by this a little bit as a committee, which I don't think is how it should be. So perhaps you can clarify some of those points for me, please.
Alan wants to respond, but so look. Living in the real world, would I prefer it that somebody didn't put something on social media without having a conversation? Yeah, I absolutely would. But as soon as you start looking at anything, and I've just been very clear, I think, that today, in fact, was the first time we even had a discussion with our board about it. So the fact that you have discussions, so not only have I heard about the minor injury unit, I've heard about a whole load of other services, by the way, that apparently we're about to cut. It is very difficult. And the same thing happens actually for our local authority and social care colleagues as well. It is very difficult to have a conversation without somebody deciding that they're going to fulfill what might even be a discussion or a decision. It is very difficult. I get that I'm pretty disappointed about it as well. But let me be clear, there is no consultation. I can see that you're looking really doubtful about it. I'm not sure what else we could do, which says you have to be able to have conversations, you have to look at stuff. And it is very difficult to have had, when we haven't got all the facts in front of us, you have to go and have a look at those facts. That prompts a discussion about a whole lot of things. I mean, we could have a discussion about some other things that we're talking about as well, which is how do you reorganise how all of your staff work in such a way that you see those most needy people, priority clinical work, and you do that in the most productive way. All of those discussions are going on. They absolutely are. I don't know, I'm not sure what else I could say. That's as frank as I can be about it, to be honest.
Philip, sorry, Councillor.
If I can just briefly go back. Okay, so passing shot, I mean, things like the urgent nurse practitioner service has been called into question, and other services. I won't go into the long list. Can I just say, please don't bypass us as a committee. Remember our statutory functions.
I'm here.
Yes, a little after the event, but
that's unfair. Let me just be clear.
Yeah, sorry, can I interrupt here? Councillor Corfon, I do have to say, your feeling about that is not my feeling. This is an important issue that needs to be raised. I do not feel we've been bypassed as a committee. I have to be honest about that, because in politics we all know the nature of social media and what comes up in that, and in terms of understanding that in its complete sense. And as Leslie has pointed out, her and Alan are here. So I don't accept that we've been bypassed as a committee, because I do accept the answer's been given so far that everything's being looked at. What's important to us, obviously, is when a plan is being formulated at the right point, we are consulted along with everybody else, because what I'm hearing from you is you're looking at a holistic solution which needs to cut money, which is unfortunate, but we all in public service have to deal with that situation, but at the same time ensures that we provide the best possible service, and there's a bigger picture in terms of working with others. So as long as we are consulted at the right time, which I hope we will be, I think we're okay. So Councillor Corfon, I think you made your point very well.
I'll go along with that, and this is my last meeting, so I'm bowing out anyway. Indeed. Keep an eye on it, please.
Definitely. And obviously, Leslie, yes, yeah.
After today with board, we will start an engagement process about talking to all of our colleagues, to Healthwatch and to others about it, to the staff about it. I mean, I haven't gone in today to speak to staff after this. We're in here talking about it. So these things are tricky to get everything in line before a conversation has taken place completely outside of anything that isn't under your control.
Councillor, if I can just make 2 points. One, which was to answer the second question from the councillor. We have to submit our budget by the end of the financial year. We have to submit our activity plan after the start of the financial year. We have a list of issues that we have got to make up any deficit. These are happening in May. It's April and May. This is very much as quick as we can bring this to you. Okay, so there will be papers that are circulated at a local level that will discuss all these possibilities. That must be where it's leaked from, but that would be far too previous to bring it to a committee such as this. Point number one. Point number two, which is how does it fit into the place-based strategy? Okay, place-based strategy, as you well know, with integrated neighbourhood hubs, Hillingdon is far in advance than many places in this country. We have a very good plan for Ruislip and Pembroke House. We have other plans that are coming in for the South East and the South West. We would not have Pembroke House and have scattered distribution of healthcare given throughout the very north of the borough if we are being sensible. So how does it fit in with that plan? Seamlessly. The timing of things is up for debate. But what we should be doing is having an integrated hub that is well resourced by our GP and also with some of our community staff. And that would attend to many of the problems that we've got. A minor injuries unit is a minor injuries unit. It's not a minor illness unit. It's not an urgent treatment centre. It doesn't do walk-in. It's not really what the NHS want to commission for in this UEC format. So I think what we're doing does get to where the strategy goes to with the hubs. Thank you.
Okay, yeah, I mean, I think what's important is obviously at the right time we are consulted with the right information of why decisions have been taken with the bigger picture, and obviously involving all those things like the Pembroke House and all that sort of stuff. So what I propose to do, go back to Lisa to let you finish off, and then have any questions on your topic, and then we'll go to you, Hillingdon Hospital, for your update beyond the minor injuries stuff.
Thank you very much for your response to that. I think from our perspective it's about managing knowing the fact that we can manage those conversations that we're having with residents at the moment, and absolutely support the wider, obviously like you said, there is a bigger picture here in terms of community services, and we've been very supportive about that. So yeah, please do keep us informed. And the last thing I wanted to say is that this is probably going to be my last committee meeting. So thank you very much for allowing us to have a seat around the table and providing updates in terms of what residents are telling us. And I hope that we've been helpful in terms of providing insight that's enabled the committee to do its work. So thank you.
Thank you. For those who aren't aware, Hillingdon Health Watch in its current guise has decided not to rebid for the new contract to do Hillingdon Health Watch services, so we'll be getting a new provider, and they'll have exceptionally high standards to meet, because you and your team have been super useful in providing us with information which helps us do our job better. So the work you and your team has been very appreciated, so please pass that back to them. Okay. Councillor Martin. Yeah, sorry, yeah. Did you? Oh, you were just agreeing with me, were you? I thought you were. Fair enough. Councillor Punja.
Lisa, I just want to say thank you for all the information you've provided into this committee. As I've been sitting on this committee, I very much look forward to your updates, and also your candid honesty as you bring updates, which sometimes are quite difficult to hear. We will miss you, but thank you so much.
Councillor Cawthorne.
Just briefly, Lisa, we've worked together over a number of years. You're with Hillingdon, of course, and Health Watch has done so much for us, going back to the time of Jeff Maslin and beyond. When we get this information, it's helpful to have an independent sense check of what we're getting sometimes. We don't always have that benefit, and it's invaluable when you can provide it. So thank you very much, and very best wishes for the future. Thank you.
Okay. Thank you very much. Okay, so thanks, Lisa, and of course you can come in on matters as they're discussed as well. So Leslie, and welcome Alan to our meeting. I know you've already spoken, but I'll officially welcome you to our meeting. So could you give us the Hillingdon update?
Thanks very much, and hopefully some good stuff too, actually. So look, it remains very, very busy, the emergency workload at Hillingdon, and actually our performance still needs to improve. Quite frankly, some patients are waiting in our A&E department far too long, and we're working very hard to think about how we improve that. I think Alan mentioned about the elective. We ended last year. Hillingdon ended last year having performed really well around the elective workload, and seeing many more patients than actually we'd even planned for at the beginning of the year. So that was a really positive thing. We continue our work actually with our colleagues in community and mental health. There's still some challenges for all of us, but we're working really hard to deal with all of those, and we work very well actually with our social care colleagues. You'll have seen, I think actually you might want to say this about the breast surgery, because that was really interesting.
Yeah, so we've been trying to make sure that Hillingdon Hospital holds its own in research and innovation, and we do have quite a lot of research that goes on there, which is a hallmark of a serious healthcare system. But we've been involved with the Royal Free Hospital, who does a lot of reconstruction surgery. So I think tomorrow on BBC London there's an item on TV about an innovative surgery that's taken place. So a patient from Hillingdon, diagnosed and treated by our breast surgeons, and the reconstruction took place at the Royal Free Hospital with some innovations to do with robotic and what have you. And actually, what it does show is we spend a lot of our time talking about some of the things that have been amiss with the care that we've got, but we do actually attract extraordinarily high clinicians performing exceptional work, And we like to bring these every month, because every month we've got a very good news story about an advancing clinical care that we're bringing.
Yeah, it's been lovely to see, actually. Just a couple of other things. I think that we continue pressing a new hospital programme around the build. It still feels a bit slow, quite honestly, in terms of getting all the permissions in place, but we're pretty determined around it, and we will keep you up to date about that, and if we need any support, we will definitely ask about that. We're doing a lot of work around the staff and making sure that we try and build staff morale there, and actually doing a lot of work. Actually, both Alan and the chief nurse are doing a lot of work around recognising and celebrating some very, very good staff there, and we're doing a lot of work together across Chell West and Hillingdon, and across Hillingdon, Chell West, and the rest of the sector, and some of the appointments that you will have seen brings that together. You'd have seen, and I can't remember if I talked about this last time. You'll have seen that about what's being asked in terms of the cuts in numbers of non-direct facing staff. We're working through that and trying to do that in a sustainable way, and in a way that doesn't affect staff morale, actually. But it is hard on staff because we've stopped bank. All the others have done it as well. We've stopped bank and agency. We've stopped quite a lot of recruitment, and that has been a bit tricky. And then finally, I should say, and this affects maybe not quite as much here, but across the acute sector, is some of the pressures from on our local authorities and in social care, and in the commissioning of services, some of the sexual health services. There's an impact actually on the financing that's coming through local authorities into health around that, but we're working together pretty well to try and make sure that we understand the money and we minimise that impact. That's a sort of a roundup.
Okay, so I'm going to ask a big broad question, because last time you came to us you'd only been in post for about a week, which was fantastic to meet you, but obviously you'd only been with Hillingdon Hospital for about a week or so. So I'm going to ask a similar question again. I mean, obviously for a number of years now in this committee, we've had Hillingdon Hospital come to us saying, yes, things were bad, we're getting better. Then we have CQC reports going, no, they're bad or they're worse. And so that's a pattern that's been going on for a long time. So in terms of your experience, and both of you, when you look at it, what do you think the quick wins are to start improving what's going on now?
I'll go first and I'll let you go. I think consistency, a consistency of approach with staff and a consistency of expectation. I think we've introduced a series of things called deep dives into every single service that looks at the quality of care, the operational performance, how we look after the staff and develop them there, and how they do that within the money. And that's actually been very interesting, but it has been accepted really well with it and responded to really well within the organisation, with people really standing up and taking responsibility. So that consistency of approach around that, I hope, will over time get us to where we need to be. We've concentrated on some tricky areas that CQC found. So Alan has done a lot of work around maternity, which you may want to talk to. Infection control has been a big issue, and actually is an issue across the NHS at the moment, but it is a big issue, and we're being really consistent about that. But just being very clear about the standards we expect, not when the CQC come. There's a thing that says, don't worry about the CQC, worry about us, worry about our patients. And a real talking about, don't walk past stuff. None of you walk past stuff that is unacceptable. That type of approach hopefully will cement and embed the right sorts of things.
Yeah, so I've been in the trust for 2 years, although I've lived in Hillingdon for 22. And I did work there when I was a very junior doctor, so about 30 years ago. And what I saw when I found was an absorption of every single problem that came to the hospital, and that's part of its attraction. It's very near Heathrow. We've got a very diverse population. Let's do as many of these services as possible, and that's unsustainable. And a couple of things have changed over the last couple of years. One key one is the acute provider collaborative, so that's working well with all the other hospitals to rationalise who's doing what. And that will pay off over years and years and years. What's happened in the last couple of months since Leslie's come is a concentration on what it is that we can control and making sure that we exert our full managerial skills on that. We've got to bring the patient's voice right to the centre of it. The clinicians solve that, and we provide them a structure that allows them to do that. We don't have so many problems, okay? We had a maternity quality problem, which I think is solved. It'll take a while to make sure that everybody believes us with that. We've got a performance problem in the emergency care, so ED, and that does cause problems to people's health, and we're taking that extraordinarily serious. And we've got a problem with the amount of money that we spend because of the staff that we have deployed, and we have to be rational about where we are deploying them. So I feel your frustration, because I read the local newspapers, which is Hillingdon's always seesawing, dolphining up and down, in and out of the water. I think there's some fundamentals in our pathways that we've got to get completely right. We've got a mechanism of doing that, and it'll be a sturdy hospital. Then when we get the keys to the new hospital, then it moves from good to outstanding, in my opinion.
So my sort of follow-up question to that, and thank you for that, is, from my perspective, there's been a bit of a gap of accountability, because we get told stuff, and then suddenly out of nowhere, bad stuff gets announced. Now, of course, improvement is generally a small step process. There are obviously big bangs within that. And so what I would like is really to get from you is, what are those indicators that can show us that things are improving or not, or what's going on, but also gives me confidence that you are doing that as well. Because what seems to have been happening with Hillingdon Hospital is either, or a combination of, that stuff wasn't being done, so senior management didn't really have a grip completely on what was going on, or essentially when indicators were coming up which weren't so positive, it was being hidden, which is completely understandable if it was. Now, obviously the truth is you can't hide things for too long. So what I would like to know really is, how are you monitoring in order to make sure things are improving, and how can that feed into us and the community to give us confidence that things are improving?
I mean, we have a number of ways we can do that, but we could do that quite delicately by looking at the quality that we provide. We've got some very, very clear national metrics that we can share with you, and they're publicly available now. There's some performance metrics as well, again, the national standard, and you should see them in how we compare to the nation, but also to the rest of the locality. There's some metrics also about our workforce, particularly our staff survey, which comes out every single year, and you can track that, whether that's going up or down. And then lastly, our finance, because at the heart of it all, if we do not get our care right, we don't get our finances right, and it's a circular concern for us. So there are four things that we look at when we're looking at a service, when we're looking at a division, when we're looking at the hospital in its entirety, and we can share that with you.
I mean, that would be great if you or somebody from your team could share those with Nikki in terms of the numbers, and maybe some sort of expectation of regular reporting. I mean, I hate to create extra work for people who are already.
We publicly,
but that would be super useful for us to be able to sort of monitor what's going on as it's going on, whatever you think is appropriate. So if somebody from your team could pick that up with Nikki, and then we could sort of get that process in, that'd be very good. Thank you. Councillor Nelson.
Thank you, Chair. My apologies for lateness. I just want to ask about the staff survey, because you said the staff survey, you're trying to deal with lots of stuff. What are the concerns that staff have that feel that it's not being addressed?
So if in general terms, and again, this plays out through the NHS, but certainly plays out at Hillingdon, bullying and harassment, some abuse actually, both for patients, and we've definitely seen some behaviour issues much more widely, and again that will be true in all services. And then a feeling within the trust, and actually to some extent this plays to the CQC and how Hillingdon and the staff feel about its services and themselves, that says we can do better, and we don't always feel supported. there is discussion, and it's part of the deep dives we do. We don't just look at performance. We look at, in this particular service, how do staff feel, and what it is that we would need to do, and indeed their direct leadership may need to do to make them feel more supported. What is it we need to do to help with their development? It's that sort of those sorts of areas that we need to do more on.
And staff retention, is that staying stable, or is it you having a quick turnover with that?
It's pretty stable.
It's quite stable, the retention. In fact, it's not unusual every month when we do a celebratory breakfast that you have people there for 20 years, 25 years, 35 years this week. So the retention is very good, and in many areas the turnover is really low. So if you take an issue that's been pressurised recently, which is our maternity unit, actually the turnover is quite low. And so there are other things that are feeding into the staff survey. People will stay there even though they're feeling not as positive about the place as they had done years before. And because it's a yearly survey, they pick out signals each year. So last year there was a feeling that people were poorly treated because of their ethnicity. We did a lot of work about that, and that's much improved. What did come out this year, though, people feeling harshly dealt with because of religion, and that's actually seen across the whole of the NHS, and I think it might be a wider political reason for that, but we're doing some work to address that.
Lisa.
Could I ask what changes have been made in maternity?
I don't know. I mean, I know we're going on to half name, but I don't think you got it. Quite a number. The first thing that we put in was a stronger governance system. So we actually understood the problems that we had. We asked for a couple of internal and external reports on certain parts of our care. A lot of it was to do with the antenatal care, so what happens in the outpatient, rather than what happens in the labour ward itself. So we did a lot of governance as well. There were certain key roles that we wanted to augment, get more of, and actually the staff leadership, we had to make sure that we had the right amount of staff so that there was a constant presence. In addition, there was quite a lot of learning that could have been done for some of our processes that we had, and part of the relationship we've got with Chelsea Westminster accelerated that, so there were some processes that went in. When we get to being an outstanding maternity service is when we truly understand our population exceptionally well. So there are certain conditions in maternity care that is disproportionately comes from different parts of our population. So are we communicating with our staff particularly well? And we've had difficulty with our translation services, which we've invested in. We've put in some technology to help that. But we're now deploying staff into particular hard-to-reach areas. That bit of work has not finished, okay, but when it does do, then we'll be absolutely outstanding. We track what we're doing by the outcome. So what mothers tell us their experience was, but also things like stillbirth rate, cesarean section rate, complications like bleeding afterwards. So we watch those things, and they've all been tracking down.
Thank you. That was useful to know. Councillor Martin.
Hello, thank you, Chair. Just a question for Hillingdon Hospital. You mentioned the continued pressures on the emergency department and the numerous hours people have to wait. In an ideal world, of course, you'd have double the size of the emergency department and an enormous amount of money. But failing that, we don't have that situation. What more can you do? Are you still seeing the wrong users in the same numbers come into the emergency department? How can you re-educate? And are any of the new services, such as going to a pharmacy for certain things, having any impact at all on bringing down those wait times to the residents?
Shall I start? Or you start and I'll jump in.
I think he's after my job, actually. Yeah, I mean, so again, in just about every in every bit of the sector, we're having a look at how we man the front door. So that one of the discussions we're having is, do you get the most senior person right at the front door that redirects patients back actually to pharmacy, back to general practice, back to home care or whatever it is. So that's one thing that we're doing. It's a balance then between those very sickest ones that our ambulance colleagues that are bringing in, and who's seeing those as well. So that's a bit of a balance that we're nationally talking about. We've also done a piece of work, and again, I should say that Alan goes down to ED every morning, first thing at 7 o'clock in the morning, well earlier actually, when he's first in, and lasting at night. So we've increased that visibility of senior executives down in the department as well. We're doing a piece of work with the emergency care, the national team, intensive support team, that says, come and have a look, come and have just a look, and tell us what more we could do. But that balance between the numbers that come through into urgent care, but who aren't really that urgent, we call it urgent care, and then those numbers that come through, the type 1s, that's where we need to, the type 1s are our sickest, that's where we need to improve our performance. We absolutely do, because those are the people that need it. But still too many people who are coming in who don't need to, and we're working throughout the system. I chair the system call actually on this, the flow board, that says we have to have a consistent offer out of hospital, otherwise that is very difficult for our ambulance services to know. If you've got something here in Harrow, something here in Hillingdon, not the same in Harrow, it is difficult because where they're driving, they need to have they need to be able to access the same level of service. That's a piece of work that's going on as well. Sorry. Yeah, I mean, I think you're right. The diversion away from the front door with pharmacy has seen a reduction. It's been useful. Being able to book into the hubs has helped. We want to be better at using it, and we want more of it because we're greedy. There are probably about 3 sets of patients who I don't think that we serve well by going through our ED. So they would be those who come from care homes. I think we have quite a lot that probably shouldn't come. Those that are frail, who we could actually deliver better acute services in the community, and mental health patients, they really do stay with us for too long. I feel for those providing the service because it is deluged at the moment, but we frequently have mid 6, 7, 8, 9, 10 patients somewhere in the hospital who are waiting to have mental health services elsewhere. So it's not 1 or 2 things in particular, it's a number of things. But to be super clear, in the past I don't think Hillingdon Hospital has been very good at identifying its needs as well as being able to take up on the offer, and we want to get that match better these days.
I know Councillor Corford wants to come in, and I'll let you come in a second, actually, just because I want to follow up on this. So how are you working together with, the Hillingdon GP Confederation, with the ICB, with, CNWL? So, because, this is, most people see the NHS, and then if they don't know what to do, they go to their GP, and if they don't know what to do, they go to their hospital. But they don't see what happens in these meetings, which are the different parts, talking about what they do, trying to work together, all this sort of stuff. They sort of think, well, why don't you all work together? So in terms of doing this stuff in order to help you with those issues, what sort of conversations and what sort of proactive stuff's happening to do that?
So we're working together, and we have regular meetings as well, and primary care, obviously from the Confederation hat on. We've got our same-day urgent care service. We've also got extended access hubs in which we are actively looking at redirecting patients, and it is happening. Obviously, once a patient reaches the hospital, it's very difficult for our hospital colleagues to send them back, but it is working. And that's what we want to encourage, and take away services that may be clogging up the system there because they are inundated as well. So looking at things like where we have same-day emergency pathways, how many of them can we relieve so that they can be seen quickly and come out quickly rather than be admitted, and what can we take away from secondary care, like IV antibiotics. So that's something we're looking at, so that the pressure on the hospital reduces, people are seen by the right people, and they can be managed quickly and out. Care homes is a problem, and we do have a care home service, and that's something that we scrutinize on a regular basis. and obviously it's the educating the staff that are in care homes, which is a regular occurrence, and prevention of falls. Falls is one of the biggest things from care homes, because then according to their protocol they have to convey unless so we're looking at things that could be introduced, some kind of mobile diagnostics, and that's something we're going to be piloting to see whether we can keep these people in. If an x-ray is absolutely fine, there's no real need to go into the hospital, because UCP care plans are, that's the urgent care plans, are written up for all of the care home patients, and they have clear sort of guidance when they need. But some of the protocols are very difficult to bypass once a patient falls, and especially if they're on anticoagulants, which make them at risk of bleeding, then they are obliged to take them in. So we're working very closely with Alan, and we are looking at pathways that where we can join up. We're also looking at how primary care element, where the neighbourhood hubs are, and the reactive care element works, and the hospital, just to look at the gap, where are the gaps, and what we can increase. Is it something that, so what we're concentrating right now on is pathways to reduce going into hospital in the first place, because there is quite a lot of differences. There are lots of services to bring people out and support them, but to prevent it going in, is the same kind of cohort of staff that we are using, and is that equitable, and is that really proportionate to what we are trying to look at. So that's another conversation. We're having a meeting actually tomorrow to see whether we can tweak that pathway to keep people at home rather than get them into hospital. So there's a lot of work, and Alan and us, we are on regular sort of meetings and seeing how we can improve pathways.
So, I mean, I know people do talk a lot and work together a lot in partnership in Hillingdon, but how does that work in terms of pooling budgets? Because obviously one of the things that was always a problem when you have different bits is you have different financial pressures. We've heard a bit about Hillingdon Hospital's financial in different bits, but sometimes the truth is, to really make those big steps, you need to pool budgets and have a sort of security of a long time in terms of funding. Because one of the things we definitely learned about when we came and saw you at the Pembroke Centre, and those with you, was that some of this good work that's being put together is happening because 3 different pots of money have been combined, but on a temporary thing, and if one of those goes, and that thing, and it seems like a really sort of uncertain way to try and achieve what everyone always talks about needs doing. So, Sue, did you, from the it says ICS, are you ICS or ICB?
ICB.
ICB, excellent. I get confused with acronyms. But yes, Sue, from the ICB, yeah.
So, absolutely, the ambition is around, in the future, around pool budgets at place. That is absolutely the direction of travel. There is a piece of work just kicking off now across the whole of North West London, including Hillingdon, where we are looking at the maturity development of a place-based partnership, with the ambition when you have a mature place-based partnership, that pool budgets then become part of the delegation of budget and authority to a mature place from the ICB, essentially, to the place-based partners. And the communication that Ritu and Leslie and Alan talked about in terms of service deliveries, the frailty stuff, the same-day access, all of that service delivery piece behind all of that is a lot of communication around the ongoing maturity and development of Hillingdon Partners at place. And I think Alan has already alluded to it. We are, in our development of our integrated neighbourhood teams and and in development of our place-based partnership, we are well advanced in Hillingdon, definitely compared to other local authority areas in North West London, and I also would say comparative across London, and having the primary care in the shape of the Confederation and our voluntary sector in the shape of 3ST as part of that partnership makes us unique and different in Hillingdon and shows that maturity. So we are well on the way on that maturity journey in Hillingdon Place Partners, and with the absolute aim of being in a place to get delegated pool budgets.
Councillor Cawthorne.
I suppose it's budget related, and it's a question that could apply to all health partners here, but perhaps I can put it to THH since they're answering questions at the moment. And it's really the impact of the abolition of NHS England, which West Treating announced a while ago. I'm not sure we quite understand what that means. How big a deal is it for us? What does it mean for us in terms of service provision, resident services? What does it mean for adult services in Hillingdon, for example? I know it's a big question. Can we get a sense of your view on it, please?
And Councillor Coughlin, I'd add to that the ICB cuts as well, because that's a really important part of it. So, yes, who wants to take that?
I'll give it a go. Thank you. There's a piece of work happening now between NHS England and the Department of Health. I think it's clear they will maintain still some distance. There will still be two bodies, but they will work much more closely together. That arm's length bit that was in place that said there was no direct ministerial control, that will go. What has been seen is that in many places there is a duplication of same teams in the Department of Health as there are in NHS England. So I think the bringing together of those teams will be a good thing, and also it takes out costs. I mean, everybody is absolutely committed to most of the money should be spent on delivering direct care, but it does have impacts on individuals, obviously, and there will be some impact on some of the ways that we do things. I think that then comes down through the regions and indeed comes down through ICBs as well, and Sue might want to say a little bit more about that. But that does mean that we will have to think much more clearly together in terms of the partnerships and neighbourhood teams about how we spread some of that responsibility between all the rest of us. And that work is going on, and people have been pretty mature about it, actually. But there are people. The other thing is there are people at the end of this who will not be in a job.
Sue, do you want to come in, especially on the ICB point?
Yes, thank you. Thanks. So, as Leslie has alluded to, this is work ongoing at a national level and coming down to ICBs, and we are waiting over the next number of weeks, short weeks, around the output of that work, and then we'll be expected as an ICB to respond to that, and how we in North West London are going to respond to that. The two areas, direction of travel is one that there will continue to be an ICB for North West London, and that the role of it's working through still from a national perspective what the role of ICBs will be going forward, but it will be much more around that strategic commissioning role, and therefore the whole conversation we've had thus far in our meeting this evening is that ongoing development of services locally, delivery of services locally, transformation of services locally in an integrated way across partners, that we have been doing in Hillingdon for a number of years. That piece of work will continue to be led and driven by partners locally in Hillingdon, with the ICB taking a much more strategic commissioning role in that, and having a staff resourcing accordingly. But as Leslie is saying, that the ultimate impact of that will be on staff who are currently employed by the ICB, who will not have a job at the end of that process.
So I understand that this is obviously very sensitive for staff in the real world, and that is very important. But one thing that I think would be really, really important is if organisations or committees such as us are sort of part of the conversation about how to remodel the ICB. Hillingdon Health Watch, whoever takes over from Lisa as well, because how should I put this? Obviously, my feelings about the ICB, what's happening in the ICB, is very mixed. Because yes, I see the problems with it, but at the same time, we always seem to have restructure after restructure after restructure. And to be honest, the sort of introduction of the ICBs hasn't even landed properly yet, and already we're going through this other major change. what I think would be really good is if views such as committees such as ourselves, and I assume our counterparts, can be brought into how we feel an ICB could work well for Hillingdon and hopefully other areas. So, I mean, if you could pass that back and hopefully see when we could be brought into that process to give our views, that would be really useful.
That would be very welcome, Councillor Denys. Thank you very much for that, and I will definitely pass that, and also the provider, the Takeover Health Watch, pass that up to our executive team, because I think that would be enormously helpful.
Great, good stuff. Okay, Sandra Taylor, our Corporate Director of Adult Services and Health here at London Borough of Hillingdon, you wanted to come in on this matter as well. Yes, well, I thought just in case if people are watching, if people aren't interested in the Arsenal Paris Saint-Germain game, they might be watching this instead, so I thought I'd introduce everybody properly first time round.
Thank you. It was just really to reiterate what colleagues from Health here have said around, first of all, our structure in Hillingdon and our place-based structure is strong, and the strength in that is actually going to take us through this journey of the change to the ICB, which is very challenging, particularly challenging for adult social care, but in conjunction with everyone sitting around this room, we've got an opportunity to manage it. Others are not in such a fortunate position where you may have a social care department stepping back and saying, well, I've done my bit, you all crack on in health. That won't benefit us in Hillingdon if we take that approach. The approach that we need to manage is a real kind of collegiate, it's our responsibility as a group. We'll deal with what's good and what's not so good about all of this, and we'll do that together to get the best outcome for our residents. That's the only way in Hillingdon we're going to be able to manage on the resources that are going to be available for our residents. So, and that, I completely support the things that Sue, Leslie and Alan are saying around, we have to look at everything. I'm doing a budget piece in a little while. We have to look at everything. We have to be efficient. And whilst I don't want to keep saying about savings, because I think we're almost past savings now to the point of we're not saving, we just haven't got it to spend, and we need to start using our resources really differently and being proactive about who needs what, when they need it, how we can do it, and how we can do it together to stop people from going to the ED, to stop people from coming to social care, if we can do it differently in the community. So it's just really to say that we're all on the same page here.
Yeah, it really pleases me to hear the sort of joined up thinking and discussions going on, and it's something I've picked up actually a lot that happens here in Hillingdon, which I don't pick up so much in other places when I go across with North West London colleagues, so that is good, thank you. Councillor Chandel, you wanted to ask a question.
Yes, thank you, Chair. This is for Alan and Leslie, coming back to the A&E. Your frontline staff are obviously under a great deal of pressure, and this might be a pie-in-the-sky question, but do you have data around patients that don't need to could have been seen elsewhere but have come in because it's just the easier option? And if so, do you have it from any particular parts of the borough so that we can then work to say, can we educate the GPs and the pharmacists, to say, look, you don't need to go there, you need to be here?
Discussions we have is a portion of patients that are admitted that are brought in from our ambulance colleagues, and I'm going to be really nice about it. But there is something that says, how do we talk to our population at large, actually, about the things that they need and what they ask for? How do we do the join up for patients who could have their IV antibiotics in the nursing home and things like that, but actually have they been seen by the GP or the nursing home staff? It's a really big piece of work. I do this piece of work nationally as well, and so there's a really big piece of work that says, how do we talk to our population? How do we talk to our nursing home and residential home providers? And we've started to do that work actually with help from our local authority social care colleagues, because they commission a lot of it, that says, let's try and actually build those relationships. It says, particularly with the frail elderly, how we keep them there. And how do we speak more widely about what services are available and make it easier for people to access them so they don't end up coming. But in direct answer to your question, yeah, we do. We can see who comes in, and we give no treatment to. We can see that. They're all patients are coded with the outcome and with the treatment that they have, so we can see it.
Councillor Punter.
Thank you. I've been patiently listening because one of the things that I wanted to ask the hospital about actually was that the patients of patients who are waiting for treatment are waiting to, they go through the process and they're not getting anywhere that end up in A&E because I just hear far too much of that, especially locally in my ward usually, where that if people are stuck in the system somewhere and their last resort because they don't know what their diagnosis is or they don't know what's happening, and I just wanted to know how that is alleviated because that I would assume is, and it is assumption, that takes up a lot of time, a lot of effort, a lot of resources. That could be directed elsewhere, and I know the joint up working, which I'm really glad to see, and it's really innovative as well. But I just kind of wanted to kind of have an idea of that pressure because that, I heard earlier that you said that the banking of staff has stopped. Is that right? So so therefore, if you've got reduced staff coming in as well, you've got to make those efficiencies work, and that patience of patience, I think, is an education narrative that kind of maybe needs to take place.
Yeah, I mean, I think you're right with the ED is always open and it's well understood throughout the world. So people will go there if they've got an access problem because they can't get seen somehow, or care that they've been given, the message they've been given has been so delayed or is incorrect, they will re-attend. You're quite right about that. It's hard to put a sort of dollar amount onto it or a percentage, but certainly, I see, like Leslie says, I'm a frequent visitor to ED. I see the patients we're attending, and I know that earlier in their disease progression, if we'd intervened, the outcome would have been so much different. And that's why the ICB cuts are really annoying, because Councillor Denys is correct. We've not got into fifth gear yet, but it's entirely the right idea. We can't do a lot of this work ourselves in Hillingdon Hospital because it needs the integrated approach. So what we're seeing is the gumming up of the machine over a number of years, and it's our job to make sure not only do we alleviate those pressures, but actually start making it better. I think we're in a unique position in Hillingdon that we've got a better opportunity than many nearby to have an improvement. But you're quite correct. Failure of the healthcare system frequently results in a deposition in ED, and they are frequently represented in those patients who we don't do anything for.
Yeah.
So they go home with a very, very poor experience.
Sorry, if I could ask another question. In terms of stopping the banking of the staff banking, can I ask if that improved staff morale, or what has it done for staff morale?
It's probably a little bit early to say. I mean, we haven't completely stopped it, by the way.
Okay.
So if there is a patient safety issue, direct care, of course we will have them. I think we've had, honestly, we've had a really open conversation with all our staff and with the consultant body, with the nursing body, that says, look, this is tricky and challenging stuff, and this is the amount of money that we're going to have to not spend. If we don't do it this way, we're going to have to do even more, many more challenging things. So I think there is something about having a mature discussion with staff about why we're doing it, and that feeling that every single one of us spends money. I mean, I was having a discussion with junior doctors the other day about, and junior doctors will say, well, I don't think I do anything that spends money. And actually, one of them said, "Oh, well, I was going to do." I may have told this story, but it sticks in my mind. But I was going to do a something or other, I think, with a patient, and I needed some lignocaine gel and some gauze. Couldn't find it, so I opened a sterile pack. It would have cost us something like £2 for the lignocaine gel, and as soon as you open a sterile pack, you spent £50. And so, trying to make things real that says this is how you spend money. You open a pack. A sterile pack, that's 50 quid. And when we asked how many of you have done that, every single one of them put their hands up. And so there is something that says you've got to have those conversations. That says that it's these things that every single one of us and needs to do our bit which that hopefully then limits the amount of direct impact it has on patients or our ability to care for patients. It's that sort of approach that we've had.
Thank you. Right, so far the meeting's been very interesting, sprawling but interesting. So, which I think some people might say that terrible chairing. I think it's excellent chairing, but I am biased, of course. But I'm going to sort of bring us back more onto track. So, if I move it on to Vanessa now from Vanessa Odlin from. Do you want to give the CNWL sort of update, and then we can ask some questions on that? So, thank you.
Thank you very much, Chair. I'm just going to try and bring out a few highlights, and I've just been making a few notes so I can try and bring out some things that have been relevant to the conversation so far. I'll start by talking about the integrated neighbourhood teams that we've been really focusing on in CNWL. We've been really focusing from our community physical health perspective in the first instance, so for example the district nursing and MSK teams, to make sure that they're aligned with the PCNs or with the integrated neighbourhood teams as they sit. And we've then been focusing on our community mental health services aligning with those. So that's kind of happening as we speak in terms of the mental health support. I would also say that we've been involving our service users and carers and what that looks like for them, so making sure that they're happy with where we haven't got to the co-location bit, but wanting to make sure that works for them. And interestingly, we are taking a bit of a population health management approach when we're looking at our older adult population in relation to dementia care. So we are working on a pilot in one of the integrated neighbourhood teams on a new dementia care pathway. I will just mention the children's health hubs as well as the family hubs. So we haven't at the moment decided whether we're going to integrate our children's services into the integrated neighbourhood teams, because we actually think what we've already got in the child health hubs and the family hubs is actually quite robust. So we think we probably will stick with that, but that's still in discussion within the system. What we do need to do is make sure we've got CAMS integrated into the family hubs. And I guess our focus around integrated neighbourhood teams is very much on that prevention point, really trying to prevent people coming into A&E who don't need to be there. If I focus then on our mental health services, we have already heard as well that there is still pressure in A&E with patients who are waiting for mental health services. What I will say to caveat that as a good news story is that we have no out-of-area patients. So all of our patients from Hillingdon aren't residing further away from home. We have been focusing in terms of our crisis alternatives on the Lighthouse, which is our crisis or our alternative to A&E. Once someone's come into A&E, if they still need some mental health support, they can come into the Lighthouse. What I will say is that our flow through the Lighthouse isn't quite where we want it to be. We need that to be higher. There is enough space for 4 people in the Lighthouse, and we do want to increase that. We've also got the MCAS, which is the Mental Health Crisis Assessment Service, so I won't use acronyms, and that is actually based at St Charles, so it's not based in Hillingdon, but it is a now walk-in crisis service. So people from Hillingdon can use the MCAS service. What we have given permission to our community services to do is if someone is in crisis and is under our community mental health teams, that they can book transport for them to get over there if they're finding that difficult. But appreciate it's not in Borough, but it is another service that's open to our residents in Hillingdon. And actually the MCAS service has seen an increase in usage over the last, certainly over the last month. In terms of, I have got some data in the pack around our patients who are residing in A&E for over 12 hours. It absolutely is not where we want that to be. We also don't want to stop patients who have a mental health diagnosis coming to A&E for a physical health issue. What we have absolutely been working on is making sure that if someone's in crisis with their mental health, that their team aren't saying, go to A&E as a crisis alternative. That absolutely should not be the crisis alternative. And we have been doing a deep dive into all patients who are known to our services every month to double check that in the notes that isn't something that's been advised for them to go to, and that they are using our other crisis alternative places. As I say, people are still waiting over 12 hours. I think for March, the March data we've got, for the month was 20 patients who waited over 12 hours in A&E for something from mental health that might not have meant a bed, but it might have been some support from mental health, and that is absolutely not where we want it to be. I won't talk too much about it because I know I've mentioned before, but the coves and the retreat remain crisis alternatives for us, and I think I have been sat here before, probably about a year ago, saying I wasn't sure whether the retreat was going to continually be funded because we'd found some non-recurrent money, but I'm pleased to say that has been recurrently funded, so I don't feel I have to fight that corner so much anymore, which is really good. In terms of our older adult mental health population, we have had some focused piece of work happening within the borough, I guess particularly with our system partners, thinking about how we can make sure that we are doing some prevention work for our older adult patients. So there's a new advice and guidance service that has been started by the older adult mental health team. So particularly GPs, but services can dial in and ask for advice and guidance. The aim is to reduce attendances at A&E, but also reduce any referrals coming into the community mental health teams where they might not be needed. And they've also now have 2 nurses who are working with the PCNs and the liaison older adult mental health nurses, again offering brief interventions and crisis alternatives for people in the older adult population. And then lastly, in terms of older adult mental health and older adult physical health, there's been a piece of work happening around an integrated pathway. So rather than for a patient who may be within the, for example, district nursing or the urgent or in the urgent community response team, if they need some support from mental health, rather than that patient having to be referred back to the GP, we've now got a seamless pathway for people to be referred or signposted actually, and the 2 teams talk to each other, which is much better rather than referrals going around the houses. Then just to focus a little bit on CAMS, and again I won't talk too much on the CAMS part because I know we've discussed that over the last 12 months. I think I sat here last time and said we had money for our mental health in schools teams to increase, so pleased to say that we've already started in 5 schools with another 5 schools starting as we speak. That will bring us up in line with the rest of London in terms of 60% of schools covered with a mental health in schools team. We wait with bated breath to see if there's more money to cover all of the schools across Hillingdon. Might be something that we can think about how we do that collectively, because again I think that really focuses on the prevention agenda. If we can support children in schools, it means that we reduce the flow coming through to our CAMS services. In terms of our young adults pathway, so that's people who are 16 to 25, we launched our Discovery College for people who are between 16 and 25, which is can be accessed by anyone who's that age. You don't have to be under any service. So we have a recovery college, and what young people fed back was it was quite hard to access. It was much more adult focused, hence launching the Discovery College. So really looking at courses and focused pieces of work to support children and young people from 16 to 25 with, for example, anxiety or depression or just worries. So if I might send some stuff around because it'd be really great to get that far and wide in Hillingdon, so we can get people using that. I've put a little bit in around the physical health urgent care response, where we're still doing really well in Hillingdon, and again that's really focused on prevention and support. And I will lastly just talk about the collaboration agreement, which is an agreement that we have with the local authority that I believe has now been signed, and that is to provide the children's services, so particularly the 0 to 19 services and the integrated therapy team for children. I'm so delighted because I know that's taken a lot of work with the local authority and CNWL colleagues to get that off the ground, and I think probably I will stop there. Thank you.
Thank you very much. Councillor Cawthorne, you want to ask a question?
Yes, Vanessa, just on the question of people presenting in mental health crisis, the past involvement of the Met Police, that's been withdrawn in the fairly recent past. Just wondered if that settled down, generally speaking, now, because there was much discussion about it at the time, wasn't there?
Yes, thank you. So yes, there was a lot of, I think, a lot of noise, I will say, about that at the time, and there was also a lot of work that went on between the Met Police and NHS providers, including CNWL, in terms of processes and making sure that there wasn't an impact. And I'm pleased to say we haven't seen any impact of that move, and we continue to keep watching it.
Thank you. Councillor Bells.
Thank you, Chair. Thank you, Vanessa, for the report. It's excellent news about the retreats being sustained funding. It's I've heard reports about it, and it's excellent stuff that you can keep it going. And it's the graph hasn't come out very well, but I presume numbers are although the numbers of people coming back to use the service again are low, but your numbers are fairly consistent with people going in there. But no, it's excellent news. And go. Do you want to say anything?
If you want, so in terms of, I think there are some numbers in terms of between April 24 and September 24. It looks like there were 94 people going into the retreat. But if you wanted some more data on the retreat numbers, I'm happy to share that. No,
data going at my head. And just on I'm quite interested in the work of the Arch, and I know you're not too close. I know you don't work at the Arch, but it's interesting to see the engaging in structured treatment following release from prison scheme, and I'd be quite interested to know more about that. What the work that they're doing in there, because it is a question. It's a question everybody tries to shy away from, but when people do come out of prison, the support is low for them. And I'm glad the Arch is doing something for people that do leave prison.
So you're quite right. I don't have further detail on that piece of work, but again, happy to either invite. I know Teresa joined me here before, so happy to invite Teresa back, or to do something separate outside of here if you wanted to come and speak to the Arch team about that.
Maybe we could have a visit for those who are interested from the committee to look at that, because I've actually never been to the Arch, and that sounds like some really interesting work. So.
Myself and Councillor Nelson went there a couple of years ago.
Okay, yeah.
And it was a very interesting day. It was on their open day.
Yeah. So maybe
very enlightening.
So maybe if we could organise like a tour and just a sort of discussion about what happens there, that'd be really interesting. Councillor Punja.
Thank you. Vanessa, I just wanted to ask about the mental health supports in schools. Because I can see, and I know that some schools have got mental health practitioners, I will call them, going in there. But can I just ask how they are being administered? And also, because you talked about, say, trying to get them away from the CAMS pathway, but in my experience, schools and teachers are actually then there's such a long waiting list for seeing a mental health practitioner if somebody is suffering from something like anxiety, for example, rather than severe depression. And then they are being directed to the GP. So I just kind of want to know, are the schools being administered, or do they know that they're not be sending children? How does that get diagnosed, and who gets to see those mental health practitioners, and are there enough?
So truthfully, if we're only covering 60% of schools, that feels inequitable for some people in Hillingdon and I guess across London. So I think that we need to be covering 100% of schools, but we obviously need the resources to do that. So I will start by saying that. In terms of how, so I think your kind of question about how, so do you mean kind of how do they link into the schools in terms of how do they administer?
Yes, or if a parent is going into a school, it's just something that I've been talking to a person that happened in their school, for example, that they were then directed to go to the GPs and get through, to be diverted to the GPs, whereas actually I thought the purpose of mental health in schools was to not clog up the GPs with something that didn't need to be clogged up there. And of course in severities where if that mental health practitioner turned around and said, you need to go to your GP and get them down a CAMS pathway, that would be a suitable resource. But for a teacher to be able to say to parents that's right, okay, you're on a waiting list and go to your GP, just feels like it's defeating the object.
Yeah, absolutely, and that would not be my expectation. The mental health in schools teams should be making sure that they are, that they're doing sessions with the children in the school. B, they should be making sure that the teachers are aware of actually if they need some support or they need some enhanced support, that the mental health in schools team will then make sure that happens. And I don't want people going back to GPs. I want people to be then signposted and referred into the CAMS teams. My understanding is that should be happening, so if it isn't, we do need to know. And the third thing is making sure, so I have seen some examples, but making sure that if you're a parent or carer of a child in any of this, in a school where there's a mental health in schools team, there needs to be information sent round. And we are doing that. So there are information evenings, so to explain what support is out there, and there also might be signposting to some third sector support that's out there that we know we've heard about before. So that should be happening in the schools, and if it's not, I'd be keen to know. Thank you.
Okay, thank you, Vanessa. Chris Reed from London Ambulance Service, would you like to give your presentation?
Thank you. Evening, everyone. If I may start with actually answer a question from the last one, because I didn't fully answer it, and I think it's in the minutes, really, about what support we have to empower the LGBTQ+ network. And so I've done a bit of digging, and actually I was really quite impressed with what I found for the Trust. I represent the Hillingdon Group, but in fact for the Trust, and we have a huge amount of staff networks where I think, and it's growing every day. I think I even seen another one that's added on, but we have staff networks for a number of groups in terms of BME, enabled, in terms of disabilities, Muslim, armed forces, women's networks that are that have been put together to kind of foster that inclusion and empower the voice to Exco, so if there is any needs. And we've seen some great improvements made for things like Ramadan and prayer rooms, where we haven't necessarily got the estate to be able to assist with some of this stuff, but actually really these staff networks are growing and growing for different areas, and that's how we're really empowering that voice to make sure that everyone's represented in the right way. So if I just may start with that on a previous question, happy to take any questions from that, because I didn't have the information to hand last one, but very pleased to be able to tell the sort of great work that's been going on with that. Again, sort of going back from what we talked about last 7 months ago, back then we started a trial at the Hillingdon Group. It was called the Holistic Operating Model. It somewhat has moved on to a different term, but actually this is all about decentralising and giving local teams the power to pair up crews, to have that that intelligence to know who works best with it, to make sure it's efficient. What we found is often if someone went sick at the last minute and we had a single member of staff that couldn't go out in an ambulance, they were paired up with someone from Edmonton. Now the inefficiencies that's got from them having to travel there, they don't know the services around, like the alternative care pathways that we want to try and use, and then they're still late off. I'm paying them overtime because they're late off back home. It's just inefficient. And we became obsessed with this sort of having to make sure the skill mixes are correct. What's really encouraging now, after about 6-7 months in of this, is that we're seeing more patients. So it sounds a really small figure, 0.65 patients per shift, but when you say that's per ambulance, per day, we're seeing more patients because of this model. So really, really pleased with the results of it. And actually we'll go on to staff survey, but actually the staff are happier because they want to be where they know where things are. They want to know where the services are, and they want to be doing good by their patients. But it's a very difficult situation. I've been in it myself, when you've got to find the maternity unit of St Mary's and you haven't been there and it's middle of the night and you're, you know, what do I do? Swan type situation. So really pleased with this. It's gone so well that it's being rolled out trust-wide. It's now called the local delivery model, and so we're championing this. It's huge change for the way systems are working. It's gritty. We're learning from it, but we're right in the middle of that trust-wide. So really pleased with how that's gone. Because quite often we'll say things we're doing, but we don't go back on it and tell you the updates on it. So that's gone well. Staff survey results are out, and we're pleased. So first thing I think we need to acknowledge is actually that the staff are filling it in. And we're up to about 80, so Hillingdon managed 80.4% of people completing it. Trust-wide, that was 72%, still kind of pretty good when you compare to other trusts across the country. There's always stuff to learn. I mean, I've put the link in the update for people to, if they want to forensically, the data is huge. I mean, you could really go to town on where it is. For me, there's some common themes that we need to work on. Assaults against staff is always a problem. How we sort this out is an ongoing challenge. Having that support from the Met in terms of prosecutions as well, something that we liaise with them about quite often, with certain particular cases. And musculoskeletal issues, again, because it's such a physical job, is another thing that I think we can always be seeking to improve on. Kit is improving. We're not having to, actually lift the patients on. The ambulances are improving in terms of preventing these, but it's an ongoing challenge. And the other one I reported on last year was the work we were doing around sexual safety in the workplace. The results are pretty similar. Now, you could interpret that a couple of ways. One, we're highlighting the issue so people are more comfortable at coming forward when there's been an issue, either from members of the public or actually, sadly, even within our own workforce, behaviour of an unwanted nature that's sexual. It's about the same. We've still got clearly more work to do on this. The results are pretty sobering, I sometimes think, but it's about the same as when we started this project. We'll continue to make sure that our staff feel safe and going from there. So they're the sort of two things. I encourage everyone to have a look at the results, and I'm happy to answer any questions relating to it. In terms of performance, our critically ill patients, our category 1 patients, we're seeing over the last sort of 6 months, we are around 7 minutes and 11 seconds. It's got a bit quicker, including the winter period. There's always work to do with performance. We have different categories of call. We're talking about the cardiac arrest patients, the fitting patients, but actually, are we getting to the patients that still need to be taken in because their blood results have come back that require A&E conveyance, but they're stable for the time being. So we have all these categories, and we've still got work to do to improve our performance in terms of looking at the borough, looking at our staffing, look at the ambulances, the actual physical fleet that we've got to do. This always goes on. But actually, our critically ill, we're still hitting that sort of 7-minute mark, which is encouraging. And actually, just looking at the data whilst this meeting goes on this week, we're well under that. You can take any particular time frame. Winter's a problem. We always struggle in winter, but actually, recently we've seen improvements there. I talk about staff sickness every time I'm here, isn't it? It's an ongoing challenge. We're still looking at the reasons. Stress is a big element of it, and musculoskeletal issues, actually injuries. We've got a huge wellbeing support network as well, with different referrals to physios and things like that. But again, it's very much a highlight because we're not putting ambulances out if our staff are sick. So very much a focus for that as well. And alternative care pathways. Are we bringing the right people to ED? And this is again because of our young clinicians that haven't got the training doctors have and our consultants have, and have got limited diagnostic tools. There's again education that we're going to carry on championing. We review the calls that we take. We're happily talk. If there is any calls that we're bringing in. The difficult we've quite often got is with the tools that we've got. The safest option is, and I appreciate that as we go in, it might not be perfect for the ED, but we haven't got the diagnostic tools that you guys have. And quite interestingly, when we bring it in, it's not something you can say, you can go home straight away. It's like, I want to do an X-ray first, I want to do a CT. So it is, we're constantly, but we're absolutely not getting it right all the time with the people that are going in, but it is constantly reviewed. So it is such a challenge. We will work ongoing work with making sure it's education for us, really, with our young clinicians of a low clinical grade, to make sure it's right, because it's not the right place. And I openly admit that we probably do take patients in that it isn't the right place, but we work on it and carry on going. Fundamentally, I put a load of figures in about sort of quality care and bits and pieces. Again, I think that's just to assure how much we're looking at it. We feed back, we look at care bundles that are required for our cardiac patients and a whole host of others. I won't go into the details, but again, it's just assurance that quality is still very much, it's not all about getting there quickly, it's making sure we're doing the right thing when we're there. And one last final one is a plug to really see what we do. Watch BBC Ambulance that was on Thursday, and I welcome any questions as a result of it.
Yeah, they still haven't come to film this meeting when you give your update. I think I mean, they're missing an important part of the ambulance service, but yes, no, we will watch that. I want to ask a question around the alternative care pathways, because I think it's a really important thing. And in a funny way, when I was looking at the statistics, it says here in the last 6 months, 48.9% of patients in Hillingdon were taken to an emergency department. I would have guessed 80% or something, because you just think ambulance goes to emergency department. So actually, that's a lot lower than I would have assumed anyway. But can you expand a bit more on how you think you can get better at that? Sure. And obviously, I would, if anybody else has any views about how they can help with that as well, that would be really useful, because I think this is something, the better we get at it, the better it helps everyone.
Totally agree. Yeah, it's and it's a figure I always struggle with. I think I've said this before here. You know, it's a figure. What we trying to, the right people have got to go to the hospital. So this figure is almost arbitrary, because that could be completely wrong, and 70% is the right number. So I do struggle with that, but I put it in for context. And also a little bit of context as well. So we have a clinical hub in Waterloo who actually can screen some of these calls and see what is appropriate for hear and treat, we call it. So actually we can deal with some of this stuff on the phone. As long as we've got the right safety netting, we've put the appropriate care pathways. And so that's part of that figure as well. We also have alternative care pathways through the iPads that all clinicians have. They give a variety of services that are provided, because we could end up in Wembley tomorrow, whole different ball game from when we are in Hillingdon. We migrate across London because we're the nearest ambulance to where we go, and it's making sure that they've got that catalogue of services for that right patient. It's that we are the only, I think we are, we're the only pan-London trust. So we have those challenges with everything different. You think of all the different complexities of the Hillingdon borough and the services that are in this room, it's very different across other parts of London. So getting MIDOS up to like that awareness around it is one part. For me, it's education. It's absolutely and support and expert. Like I say, we have young clinicians who of a variety of clinical grades, from assistant ambulance practitioner all the way up to advanced paramedic. And it's making sure that they're aware of safety netting. So we have things called Pathfinder, which is a tool to make sure that we're not missing any RAVE-FAB patients. We have also clinical advisor. If they are unsure, they can ring the local, Waterloo to get advice from a senior clinician. And we have local senior managers, so we call them clinical team managers, who are there also to provide support actually in person if they request it. For me, your answer to sorry, I've given a very long answer to a very simple question. It's education, really. I mean, yes, Leslie.
So yeah, and I think actually one of the things we've all got actually is with international nurses as well is a lot more education that we need to. The other thing is actually it doesn't just sit with the ambulance trust, as hard as I might be on them at times, which is there are things that we have got to do consistently that says. Can we consistently give IV antibiotics in the nursing home? Can we actually do something that says as soon as we get to an A&E we'll x-ray them, and if they're okay we could send them back? There are things we've got to do as well, but that is a piece of work that we're working on. It just isn't the ambulance trust.
That's a really good point, thank you. And it's really difficult because some of the services that we want to use have limited time frames. You know, open between 6 and 10, and then we're there at 12. Do you see what I mean? And it's that inconsistency. Now, I haven't got the solution to that, obviously, because obviously it's a much more difficult puzzle than say, well, let's just open 24/7. But that causes a challenge sometimes. And if I'm being completely candid also, it's very good what we all agree in, you know, when it's all being commissioned. But actually, when you get gatekeeper to the clinician, sometimes it's difficult. And actually what we need to do is actual good handovers. And this is part of the education, so that the people we're handing over to have that assurances that everything's taken into account, so they can safely take that patient without ED. So it's a really big area that we're working on, and hopefully we'll continue to improve it.
I mean, ideally, the answers that are given to your staff would be easily accessible to those you drop them off to. So if your staff, if the ambulance staff obviously check somebody out in certain ways, yes, get answers, who you drop them off to should have those answers, so they don't need to ask the same questions again.
100%.
And no, I mean, I don't know how it works. Maybe that does happen like that.
Well, it's so interesting. So, no, absolutely. So we need to make sure we're giving that right information to the person that's going to take on that care. And we have these sort of structures, SBAR handovers, all these sort of ways to ensure that that's clarity. Being a clinician myself and knowing I'll ask the same questions because I don't trust anyone, so it's going to happen anyway. Do you see what I mean? I'm going to want to know at all. But as long as it's the safe thing for the patient, I haven't got too much of a problem with that.
Yeah, no, I understand that. Councillor Corfin.
I'll pass this time. I think you've more or less covered it with your question, so I'll leave it. Thank you.
Thank you. Councillor Bell.
Thank you, Chair. So, I see you're doing work on your sickness levels, etc., and it's disappointing that they've been high. You see, you hear stories of ambulance crews as well as fire crews, etc., being abused in their job. What's the level in Hillingdon? Is there high amounts of abuse of ambulance workers in Hillingdon?
Sadly, yes. And I don't think it's unique to Hillingdon. I think it is pretty standard across the trust that we are in people's houses in their hour of need, and there could be other factors that play to it. We do, to try and prevent this, we do a series of core skill refreshers about scene safety and ways to prevent this, de-escalation training. We do everything that we can in that respect. But sadly, yeah, it is regular. I think is probably the best way on it is. What we do though is we have a system called, it's radar now, historically Datex, where anyone who's assaulted is met with, we look into it, what are the causes. We have a location alert register, so if physical contact's been made, we write to that patient and we put an alert on to warn crews in the future. Sometimes it requires that we don't go in until police have got there. It's been so serious in the past. There's different levels of this to make sure that our staff are safe going into it and they've got that warning. It's a really difficult balance though from preventing care, because in their hour of need at that time they still might need us, and it's a very difficult case of not going in to provide that care. And it falls down to sometimes the sort of duty of care that NARU, our National Ambulance Resilience Unit, talks about, is the need to mitigate risk but actually accept some for the duty for the care of those patients. So it's an ongoing battle, and we liaise with the police quite regularly about it.
Thank you. Councillor Martin.
Thank you. Just a quick question about, I asked the same question to Hillingdon Hospital, re-educating the general public into their use of the ambulance service. And I'm just wondering what sort of wastage you see, if you can use that word, of people calling. And to my shame, I'm going to admit, I watch Coronation Street. And every time someone falls over, bangs their head, anything really minor, they call an ambulance, educating the public that an ambulance will turn up within 10 minutes to take them to the hospital. Yeah. And I'm wondering whether there's a way, with using the soaps, in all seriousness, to highlight that we don't need to call an ambulance. It's not a taxi service. It's a service that, do you leave patients to say you need to get a cab and move on to the next one? Is that something you can actually do? Because
it's something we do. Yeah. That's absolutely something we do. So, do they actually need? There'll be times when they need to go to hospital, let's say because of a wound, a closure that we can't do out in there, but they don't need an ambulance to take them. So often we'll encourage them to make their own way, and we've got the electronic care patient records now means that they can be accessible, so we know that that's going with them as well through, thankfully technology that's moved on. We also leave people at home if it's not appropriate. So it's a difficult one, because in their hour of need, that people do panic, and I get that, and we're all human, and so we're there for them in that, but it doesn't mean we're going to just take them to hospital. We will provide the advice, the assurance, leave them at home, and that's why that figure of 48 point whatever I provided is that sort of level. A lot of people don't, but we can help with telephone triage. The hear and treat will actually often provide some of that reassurance before we even get there. Sadly, in that panic and that hour of need, they often don't tell us the truth of what we're going to, so we go into something else. But it's always, we think, manage that not everyone goes in. Not everyone's done. We can make sure that we're addressing whatever need they have.
Okay, thank you. I'm going to bring Sue Jeffers and Sean Bidwell. We haven't introduced you yet, so if you could just introduce who you are, because you've not attended this meeting before, and Dr. Ritu Prasad, because I know you were heavily involved in parts of our earlier conversation, but also I wanted to give you a chance just to talk about some of the other things you wanted to. So first, Sean, if you wouldn't mind just introducing yourself.
Hi, so Sean Bidwell, North West London ICB, work with Sue in the Hillingdon Borough team, so I've kind of come just to sit with the team this month, so I'll likely be here at a future meeting.
Well, welcome. And welcome, Sean. And so, Sue, is there some other stuff you wish to talk about?
Yes, thank you, Chair. So I have in the slide deck that I have sent in to you, I've got a bit of an executive summary that then supports the slides behind. There was just a couple of things I just wanted to pull through in particular and then open to questions. On the performance slides, so this all essentially relates to 24-25, and you can see that Hillingdon's performance compared to our other colleagues across the rest of North West London, we are all green apart from 2 ambers. And in terms of our cervical cancer screening rates, we remained, Hillingdon's performance remains the second highest within North West London, and our GP lead for cancer has been attending primary care network meetings during Q3 and trying to support practices in improving their performance. And in our 2-hour community response rate, essentially there's been some of the elements in terms of reporting that is reported here, but also across Hillingdon we've been through the last weeks. We've had somebody working with Vanessa's team in looking at our urgent response services and doing a capacity and demand exercise. So we're about to get some of the outputs of that. So hopefully that will improve the 2-hour community response. So there are 2 ambers, pleased to say all the rest are green, and with particular emphasis, I think it's really brilliant for our general practice, for our patients who have long-term conditions, our children with asthma, our people with serious mental illness, and our people with learning disabilities, that their annual health checks are all, being done. So that's really, really encouraging. On the estates, I do have to talk about the work starting in Northwood and Pinner. I think this must be the first primary and community healthcare estate development in Hillingdon for years, so it is really gratifying to see it underway, and we have a groundbreaking ceremony on the 7th of May, and I know councillors are invited, so that's really, really good, and it's so far on track to deliver by May 26th and have a new community and primary care, and we've got 2 practices moving into it. So that's really good. I want to draw the committee's attention to the health inequalities transformation slides on 6, 7 and 8 of the ICB pack. So just really, this is a really exciting piece. So we've talked already around the development of our 3 integrated neighbourhood teams and the work that they are doing. The health inequalities funding is coming through in 2 ways. There is health inequalities funding coming through our public health team, so the Children's Community Oral Health Programme that's there, but and the community champions, but there's also health inequalities funding coming through the 3 integrated neighbourhood teams, and they're putting in bids for our funding and being successful in that, and that's really focusing on prevention and proactive care, and focusing on those people who are most deprived and are most at risk of health inequality. So that is really, really transformative work that is going on and underpins our integrated neighbourhood teams. And then I know a really always has been a key of key importance to this committee has been access to primary care, and so we've got, as Lisa alluded to in your presentation, Lisa, North West London asked our primary care networks through October and November of last year to carry out engagement exercises with their patients in their primary care networks, and that the output of that is represented in the slide deck. But I just wanted to bring some data to, and then data to you, but as a result of the engagement exercise, North West London has commissioned what is called an access specification for our primary care networks, starting on the 1st of April 25, to really try and improve access to general practice across our primary care networks, but also with a focus on continuity of care within that. And Rishu and I can add to answer people's questions, but just some data that I gathered, which is not in your slide, but I wanted to add. GP appointments in Hillingdon went up 9% in 24-25 compared to the previous year, and across North West London, month on month, 20% more GP appointments across North West London compared to the plan of 15.5 million appointments for 24-25, and the plan for 25-26 is 17.1 million across North West London for the year. And of those appointments in 24-25, 67% were face-to-face. And I do have some data on dental, because I know the committee is also interested in dental, which I can share. But dental activity, so we contracted in 24-25 across North West London, 3.1 million appointments, and the uptake was 96.5%. So of that contracted activity, 96.5% was actually delivered, and that is activity above pre-pandemic levels.
Thank you. Dr. Ritu Prasad from the Hillingdon GP Confederation, is there anything you would wish to add?
Sue's given a lot of information, and we've kind of done our presentations to you as to what we're doing within the neighbourhood. So we've got 3 neighbourhoods, one in the southwest, southeast and the north, and we are focusing on priorities which align with what we need within Hillingdon, but also with North West London, and also national targets for integrated neighbourhood teams. And in the southwest, we are dealing with priorities like the children and young people's health, while in the north, because of the dynamics of the population, it's based more on elderly population and frailty, mental health, aligning the pathways and post-dementia care and respiratory, which is a big problem in the north. So we're working with different partners. Some of the projects are with the hospital, some of them are with our partners' organization, but there's a lot of work being done on prevention now, that because that's going to help us in the long run because of the nature of our population. So I think the slides give a detailed sort of description of what's been happening and how we're going to be delivering all of this, basically. So unless anybody has any questions, I won't expand on that, but happy to answer any questions.
For everyone else's benefit, the committee actually went to the Pembroke Centre last week and had a really good presentation and asked lots of questions. So I know Nikki's written up a notes or a minute of it. So I wondered if that or a version of that could be appended to this meeting's minutes, because I think it's useful to put those in the public record. That was to do with our main investigation that we're doing about improving preemptive care in Hillingdon. So that, I mean, it was really useful. But I won't go over it again because everyone's been here for quite a long time so far. But thank you very much. The only thing I want to highlight really is I'm really interested to see how the Community Champions project goes. And I know, I think it's a really interesting idea and one that hopefully can improve preemptive work. So I know I've seen down here Brunel University have been commissioned to evaluate the project, which I think is super important because we need to evaluate what we do to try and find out what works.
Yes, thank you very much. So just 2 things that are really interesting about the Community Champions. So the model originally is based on a model that started in Brazil and was really successful in Brazil. Westminster City Council picked it up working with health, and it has really, really worked well there too. So we are, partly what Brunel are going to be doing in their evaluation is assessing whether the Hillingdon version of the model is the way going forward, or whether we need to think about a bit more the way Westminster have been doing it. The other thing to think that is really helpful, it has been a little delayed in getting off the ground, partly because we started in the south of the borough and because of the high level of deprivation there. But interestingly, because Harefield is a pocket of deprivation in the north, actually we decided to move the project to the north, to the Harefield area, so it's very much concentrated on that pocket of kind of hidden deprivation and trying to do community development in a very deprived community.
I think we'd be really interested to find out, how the research goes and what is found on that area. Okay. I see no questions on this, so thank you very much. So I'm going to go lastly to Derville Russell from Royal Brompton Harefield Hospital. Sorry that you're last. I promise you can go first next time.
Apologies. In the interest of everyone, I'll try and be brief. So you'll find the report in your packs. Start a tiny bit about performance, if that's okay. So elective activity in our waiting list generally are lower than they were the last time we talked to you. I would have expected them to be a little bit lower apart from our Synovus, our pathology system cyber attack that happened in 2024, and that resulted in us losing quite a lot of activity whilst we found workarounds for getting pathology results and blood matching and everything like that. We're still on monitoring patients who are waiting longer than needed so their care can be escalated appropriately. So you've got the figures there for info. In terms of the March 2025 target of having no patients waiting more than 65 weeks, we had one patient, so we didn't even have the glory of saying zero. Patient with an extremely complex pathway who has asked to defer their date but now has a date. So we were nearly there, but hopefully on an ongoing basis we'll be able to maintain that. Diagnostics has been improvement since I last spoke to you, particularly in the area of echo. We are doing a transformation project looking at more ward-based echo to try and speed up discharge of patients from hospital, and we've also reconfigured our space to do an extra outpatient screening room, which is good. Our main problem is sleep studies still. Performance has improved considerably, but still we're only seeing 60% of patients within the required 6 weeks of their test. I'm hoping by the time I come back to you, that figure will be nearer the compliance rate. In terms of some good bits of news, and actually I'm going to copy Chris in your style. Last time I was here, I was asked about the lung screening, the targeted lung health checks, now the cancer screening programme, and how successful it had been. So I included a couple of figures there. So these figures that I've provided are specifically for the West London scanning programme, which is the one that Harefield Hospital is involved in. We basically lead on the scanning review meetings, which is where all the scans that are taken are reviewed by a clinician and patients are sort of signposted to where they need to go for onward care if necessary. So I thought this figure was worth reading out. 190 new cancer cases are being detected a month in the West London Cancer Programme, lung cancer programme. Since the programme began, 6,000 cases. 76% of the patients were diagnosed with lung cancer at an earlier stage, sort of staging at grade 1 or 2, that may not have been detected without this programme until a later stage when potentially their prognosis was poorer. So I think that's quite an amazing thing for that screening programme to have achieved. Hairfield's also starting to screen for GPs in wider areas now, Kingston and Harrow, and we're also providing additional scanning capacity for other areas as well. Transplant activity, quite a good year in the year that's just gone, 24-25, 36 heart transplants, the highest of all the transplant centres in the country that are doing heart transplants. Lungs, 26, which is slowly coming up, but it's way lower than we would have seen 10 years ago because of the amazing drugs that are available, particularly for cystic fibrosis, which was one of our main reasons for lung transplant previously. 30 years of mechanical circulatory support, because we always refer to it with abbreviations, MCS, and I'm trying not to use abbreviations. There's going to be a bit of a celebration at Harefield in the summer about this. This is a fantastic service that can support patients' heart function either in the short term, for example, while they're waiting on the super urgent list for a heart transplant, or in the longer term, whilst they get fit and are in a better physical condition to be put on a transplant waiting list. Heart attack centres going well. In terms of door-to-balloon time, we are achieving the NICE recommendations of 60 minutes, and we're actually the best in the country. The call-to-balloon time, which includes the ambulance journey, we're still third in the country, so that's still a really good result as well. Final thing for me was we continue to develop our clinical strategy at Harefield. We're looking at plans to strengthen the academic links and to develop more specialist research. The aim is that this clinical ambition will then help us with the vision for what Harefield Hospital may need to look like in the future. So we're sort of at the end stages of developing the clinical strategy now, and the next time I come I should be able to find a more fuller update.
Thank you. Well, I think the prize you get for going last is no one's going to ask any questions. But next time you'll go first, so you can give us a more fuller update on that. So thank you very much for that. Always great to hear about the work that's happening at Harefield, Royal Brompton and Harefield Hospital. So I'm going to close this item now. So thank you so much, everyone, for coming. I know it's a long meeting, but I think it's great having everyone together because, you know, then the conversation can go in the direction it needs to be. So we will continue because we're now going to discuss the adult social care budget. But please feel free to go, everybody else. Unless you really want to stay, then you are very welcome to stay. Yes, Sandra and Martin, you have to stay. Okay, good stuff. Okay, so we're now going to move on to item 6, which is the budget spending report, select committee and monitoring. So initially I thought this would be just a verbal update because I was under the impression that June would be the main time when we get the main stats, but a paper did come through yesterday or today, I can't remember, which we have here. I really haven't had time to digest it, so what would be really useful for me would be to get an explanation from both of you about how I read this information in the future. So as well as talking about what you wish to talk about, if you could talk through what this information means and how we should read it in terms of understanding what's going on with the budget, that would be super useful. So Sandra and Martin, I don't know how you want to you can deal with this. Whoever wants to talk about it can talk about it.
So I'll start and do the kind of scene setting, and then I may need Martin to jump in around some of the detail around the finances, which he very helpfully provided. So in terms of getting the report to you, in all honesty, I felt that you hadn't got one and other committees did. So I felt that I should have put something together for you because I had intended, as per our conversation, that we were having a verbal update because this is the first time that we're talking about budgets and how and which we're going to monitor them going forward. So I thought I'd just set the scene by saying a few bits about how we monitor the budgets, but also about setting the scene of what adult social care spend and activity is like at the moment. So we've set out in the report that you have the high level wording which just talks about how the budget is going to be set. We're at a point in time now where we're just closing 24-25 budget. We're building the new budget for next year, and at the committee in June we'll be able to report on outturn of 24-25, which I'm assured by my finance colleagues that will give us actual, so we'll know what we've spent during 24-25, which is really helpful because the way in which we operate our budgets is that we work on a forecasting model. So we expect to understand almost at month one what we're going to be spending for the year based on the collection of data, the understanding of our demographic growth, so the number of people coming through our door, and how much the cost of care is going to be. And ordinarily, over recent years, that would have been fairly accurate, and we'd have a fairly good understanding come October time, so half year we'd look at that and tweak and see if the modelling was right. We understand how many people are coming to us for new packages of care, how many people are leaving us, and what the expected cost will be. Since the COVID pandemic, that's been incredibly difficult to predict and forecast because the demand pressures which have hit all of the colleagues we've talked to in health in the room earlier, it makes it very difficult for us to predict who's going to come to us. Some of those people will have been impacted by the pandemic, some of those people will have been impacted by the delays in treatment at hospital. So you can see that they're coming to us very late in their illness, in their surgery journeys, and need additional support. So they might need further interventions that we weren't planning for. So the forecasting of adult social care budgets has become very tricky and really needs significant support from our finance teams to help with that, and looking at data, the growth of the number of people coming into the service. But additionally, what we really need is to understand our care market, which has become incredibly expensive, incredibly challenged because of the numbers of people needing support, and it's been really difficult to be able to understand price variables within our local authority, because we are an outer London borough and we experience high demand from inner London boroughs such as, well, still in North West London, but Kensington, Chelsea placing, Westminster, but much further and beyond that. So that has challenged our care market, which gives us a significant pressure in the cost of care locally. We're taking steps to challenge that care market and deal with that, but things like the additional national insurance cost to social care providers, which is not funded, has put an additional pressure on, as well as a change in the living wage. So those additional pressures, with the fact that we are financially challenged as a local authority, but a care sector, we're financially challenged, means that providers are looking to us for significant increases in fees, and we're already at the top end of what we're paying for our care. So we have been working with our care providers, and we have been talking about the fact that inflation this year is at a very minimal rate that we're able to offer, if at all. We pay a fair rate for our care, and we're at the top end, and that top end is driven by market forces, so demand. So some of the areas for us to work through are, well, all of the areas fundamentally are around placements and the cost of care in the market. So my savings target that you'll all be monitoring and scrutinising over coming months and the year will be around how we're addressing significant costs in staffing and significant costs in care provision, and how we're tackling that care provision, the projects and activity that we're undertaking to try and address the cost of a nursing bed, for example, and how we can reduce that and how we can work through some of those areas of spend. We're working with providers, obviously influence from places like ADAS, the Association of Directors of Adult Social Services, talking to government about the fact that social care providers are particularly challenged by the NHS, the National Insurance issues. I'd like to really talk to you all and explain that we actually, as an adult social care department, I've talked to you recently about our really positive outcomes. So our data tells us that we are low spending, believe it or not. As an organisation, the spend per head of population is excellent value. Our reablement service that is a really good quality care offer for residents both in the community and out of hospital is a really good lowest value expenditure in North West London with excellent outcomes. More than 90% of people have no ongoing care needs as a result of that service. So where we're looking at making savings within the service, what I'm talking about is being more efficient, because actually the funding that we're allocated in terms of adult social care is extremely tight. And so we've made savings through this year, and we've delivered all of the savings that we intended throughout 24-25. In 25-26, we've got real challenges in terms of reducing that cost of care. And that is about our partnership working with providers, about ensuring that we're getting best value, carrying out reviews, not using agency staff in exactly the same way that Leslie said if we don't need to. And that is, we have a statutory duty to provide services and ensure that those statutory duties are met. But it might be that we won't be doing some of the above and over and above services that we have done in the past. We will focus everything ensuring that residents are not detrimented and carry out our statutory duties. That's not in question. What is in question is about how we deliver that sometimes and how we actually get best value out of some of our care provision, and some of that will be about us doing that ourselves. And ensuring that we meet the demand in a way that is safe and is not going to challenge the service to reduce our rating of good with our CQC inspection, but know that we have to make those savings. So it's my intention, the process of budget monitoring will be that we will, as the Oracle system comes up, I will see the budget for the whole of my service area, and each of my assistant directors have a range of services that sit underneath them, and they have a range of budget managers that run each of those services, and monthly they will report in the system, so they monitor all of the expenditure and the income. Really, really important that we get the income from the Better Care Fund, from the ICB, particularly with the ICB, because we have a claim relationship with the ICB, so we have to make sure that we work with them very closely, and that any income that we have is tracked and we ensure that we get it. For example, in one of the care homes, I've been out on some visits today, in one of the care homes that we run ourselves internally, we have 3 placements for people from other local authorities, been with us a long time, but they bring in an income that sustains that service for the rest of the people living there, which is incredibly helpful. So we have budget managers monitoring their income targets, managing their staffing expenditure, literally to the hour. We monitor staffing expenditure to make sure that it's managed properly and appropriately. If we don't need to use agency staff, then we have a vacancy, and we've got agency staff in there because many of our services are 24-hour absolutely essential cover, then can we convert those agency staff to permanent so we don't get that margin on top of that? But we're looking at a range of things that will help us, that I'll be able to talk to a little bit more in the future. As I come back in June, I'll be able to talk to you about some of the projects that will be off the ground by that point in time, which are just in the process of doing that, but I can't share information on that at this point in time. So I'll probably hand over to Martin, but essentially in my savings for this year I have £7 million worth of adult social care savings, with, I have to put my glasses on for this number, £5 million of growth coming into the budget to ensure that we've got sufficient to cover the additional people that we're expecting to cater for. And as part of that £5 million, we've also got growth in there for public health, because public health is included.
Right, thank you. I'm only going to really say two things. Sandra mentioned that we're closing the 24/5 accounts, so just something to say on that. And then I think I'd like to point to almost the two figures in Table 1 in this report that I think you would be most interested in knowing more about at the next meeting. So 24/5 accounts, the monitoring of spend both on staffing, on in-house services and on external placements is really quite detailed. A lot of engagement from Sandra's managers with support from finance staff. It will still be very important when we know where it's landed, that we understand anywhere where it's different from what we thought it would be, and we can explain that and we can learn from what we find. I'm hoping it won't be very different because of the work that goes into it, but I can't promise that to anyone. The second thing, that Sandra's mentioned savings, 7.2 million in that column-headed savings. There's a detailed list behind that. I forget how many savings proposals that were included in the budget papers that went to Cabinet and then went to Council. We'll be monitoring those closely. They're not all going to happen at the beginning of the year. Some will be phased through the year, and it'd be very important to keep a close eye on anything that's at risk of slipping. Slipping during the year, or possibly the risk of slipping into the following year, which obviously has an impact on the Council's budget, on its reserve levels. The other figures in here are in the growth column. The top one, 1.35 million, that's essentially the increase in the public health grant, which has gone up from a bit over 19 million to something over 20 million. The 3.65 million growth in for adult social care placements was based on forecasts of demography that was already happening, but of future demography. There are two things that could affect that. One is the pressure of people presenting services and how effective adult social care can be in meeting their needs in more affordable and innovative but still appropriate ways. But the other thing, of course, is going to be the pressure on prices that private sector and independent care providers charge for services. Increasing internal capacity will help with that, but providers really are stretched because, in particular, the national insurance increase, which is a problem for them and it's a problem for the council, and that would be possibly the most significant area of risk, I think.
Thank you both. And this is a subject we're going to come back to again and again and again, so we're going to become more au fait with it. I've got one ask and two questions. The ask is, I know Nikki has mentioned that there's been some thinking going into this as well, but I think like a separate training session for us committee members or on this would be extremely useful, because just to make sure that we can understand what this stuff means and how to interrogate it. Yeah, if you can, yes, please.
So I don't know if all members are aware, but there's been some discussion in Democratic Services, because this is a huge undertaking for members of a committee that doesn't normally deal with finance. So what we're proposing is to actually organise some training for all members, but particularly members on scrutiny, about scrutinising local government finance, local government budgets, hopefully either towards the end of May or beginning of June, so that it's prior to all of the select committee meetings in June.
I mean, I think that sounds really good, but what I'd like to add to that is maybe a specific section on the health and social care budget for us, because otherwise we'll have an incredibly long meeting with lots of questions, which are sort of more educational questions that I think we should possibly do better in training. So I think that training sounds excellent and something that we should do, but I think more specific training on how to sort of read and understand the social care budget would be super useful as well. So if we could look into doing that, as long as the rest of the committee agree, if they think that would be useful. Yeah, excellent, good stuff. One of the questions I wanted to ask is, the ICB, obviously they've had their money slashed. Is that going to affect us and this?
Yes, in short. So the funding in the main, the ICB, that we receive adult social care benefits from the ICB funding in two ways. One is that they directly commission some services that our residents benefit from, and if they withdraw those services, then the slack needs to be picked up somewhere. And the second is through the Better Care Fund. And our ICB in particular is very financially challenged in North West London, and we have had some proposed, it's not yet signed off by Health and Wellbeing Chair, so, but we have had some proposed changes to the additional funding. So that's what the ICB don't have to provide, that they choose to provide to adult social care and the wider system. And I think I can't really reiterate enough that if they do something to the wider system, it has such impact on us too. So even if we say, oh no, it didn't really impact us, if they stop doing something that the Confederation are doing or supporting the community for residents, it's going to impact, which is why it's so important that we retain our place integrity and work together to address the real challenges that we've got. The ICB challenges are significant, and it's not, we haven't signed off our Better Care Fund plan as yet, so we will be doing that in the next week or so with the team, and that will come back to you at some point.
So essentially in June we can we'll know what's going on that. Okay, excellent. And my last point, which is sort of like a slight question, but really a point maybe to go into more detail next time. I think it's really important for us to understand what the statutory duties are and what we deliver for the statutory duties, what we do which aren't covered by the statutory duties, though still might have great value, so it's not a case of throwing those away. But I think it'd be useful for us as a committee to know what those are and what those aren't. And also I think it would be really useful for us to investigate. So a statutory duty might be you need to do X, but obviously how you do X can differ, and obviously different people might interpret that, so we might get challenged on our statutory duties as well. So I think it's really important for us to understand more about that as a committee. So I suppose a request is that when we come to June, if we can have some more detail about that.
I think I can give you a very quick example of a knock-on effect, as you've just described, of statutory duties. So we have a statutory duty under the Care Act to carry out assessment, and if somebody has eligible social care needs, then how we support them to provide that, dependent on whether they are eligible for funding from the council and social care to provide that, or whether they contribute towards their care, is irrelevant. They've got eligible needs, they have a financial assessment, separate that out, and who and how that's delivered is is determined in that way. So that gets us to the provisioning of care. So once we provision that care, if we're funding that care because somebody has eligible needs and they're entitled to have that care, that could be, as an example, daycare. Daycare is a non-statutory service. However, that person's eligible needs might indicate that they need a level of activity to sustain their social lives and interactions, prevent loneliness, etc. So the function of daycare is non-statutory, but the eligible needs still have to be met. So I could say, I'm providing a day centre to certain people within this borough, or daycare that is funded in a day centre. Day centre's not a statutory duty, but if I withdraw that service, then the eligible needs still needs to be met, so each individual would then still need to be funded. So if you take away what is non-statutory, you still have the statutory duty to provide that service to somebody, which is almost bizarre in its analogy, but in probably 10 years ago, people closed day centres because they said they were non-statutory and they're expensive to run, etc. But those people still have that eligible need for social interaction. You can offer a direct payment and say off you pop and arrange that for yourselves, but in the main, the people that we're providing that service to need that level of support, and it's the most cost-effective and efficient way of doing it. So those are the things that we have to take into consideration as part of that statutory versus non-statutory.
Thank you. That was a very interesting example I was not aware of. But more understanding of those sort of decisions would be really useful for us, I think. So
we could perhaps talk you through the Care Act domains, which tell you what is eligible and what is not eligible, and how support is considered in each of those domains, and what will drop out of that at the end of it will help people understand.
Thank you.
Also, perhaps the duty that the Care Act placed on local authorities, almost in legislation for the first time, to provide preventative services, which in themselves are not individually statutory, but they are really important for tackling people's needs at an early stage before they come into statutory care.
Thank you.
And that's vital, that we as an organisation have public health sitting in my directorate, so that we can drive the early intervention services and ensure that the people are well supported with supports adult social care budget.
Thank you. Councillor Cawthorne, did you have a question?
It seemed tough in my day, Sandra, and it's 10 times worse, isn't it? Indeed. I'm sure you'd give your right hand to be back where we were all those years ago, wouldn't you? Couple of questions from me, really. I mean, when we're looking at savings and efficiencies and what have you, what we're familiar with, some of us, is this idea of expressing them in terms of what's reasonably bankable within our grasp, what's more stretching, what's more of a risk. Is that sort of reporting what we can expect moving forward?
Yeah, absolutely. We do that. I do that monthly. I do it with my team weekly, and we have a RAG rating system. We have a profile of all of the savings and how we're working through them, where we've got to. And we're taking a bit of an approach this year, which is quite new for us, which is around, so if we break it into quarters, how are we doing? And will we get there? Which is why we're monitoring it weekly in the directorate. And what's at risk? We do have to take a risk in some of our savings and say, actually, we're putting that in and we're going to go for it. And if we don't achieve that, we're going to have to find a different way of picking that up somewhere else. So there is that challenge for us in
May I? I mean, you're right. It's always been about managing risk, going back to my day. Just a further question. Quick observation. What I mentioned earlier about NHS England. I mean, your answer a moment ago illustrated, I think, more fully than the discussion we had earlier about the degree of the challenge we now face with some of those changes. Quick question around the care home acquisition, which I think I can just touch on. It's in the public domain. I won't get into part two, but I'm wondering whether we've been prudent in our assumptions about savings that are riding on that, because that's very much part of this year's budget, isn't it? So
we have been, in my view, extremely prudent in that, and I hope when we come back in June we can go into a bit more detail about that and how that's going to look at our operating model for the future and the difference that should have on how we manage our care for our residents, because the priority not only is around being efficient, but if I have to send someone 50 miles up the road for a placement which I've got to send a couple of people off to Aylesbury at some point soon, we want to bring them back. They should be local, and we should be able to place people locally, and we should be able to afford to place people in our own borough. So that's a massive piece of commissioning work that we've got that is included here, and we need to tackle. So it's going to be a challenging year.
Thank you. Councillor Punja.
Thank you, Chair. Just following up from Councillor Cawthorne's response about kind of the risk management. I assume your RAG rating system would be like a traffic light system or something like that, so we can kind of clearly identify those slippages are happening, if they're happening. In the light of transparency, could we ask that, because when I first read this, I thought that the red figures were deficit figures, as would be in normal cash flows, and actually I understand that they're income figures. So that would be just a footnote saying that, so that we understand that clearly, would be really appreciative.
I made that same assumption, but that is useful. What I was then, as Councillor Denys has already said about kind of like the detailing of the breakdowns, because I think that would be really appreciative. And then my last question is, because you have talked about Oracle, and that came up in the budget beforehand, of where are we with Oracle, because there was real concerns about it providing the high quality data to make the decisions that have been made for the forecasting. Where are we with that, and why is there only two places where we've got growth predicted? I'd like to know.
Do you want me to do that, or do you want to? I'll give it a go.
You're more than capable, Sandra.
I'll tackle the Oracle point. We have had challenges with the system. It hasn't given us quite the answers we wanted last year. There's a task force working on it night and day to actually get us ready. So what we really need is our budgets now for June, and for us to be able to give an outturn position of last year, and as I said, to look at the actual, so we know we're on the right track, we've got the right understanding. Our budgets are built around our staffing structures. Last year was a very busy year in terms of lots of change with staffing structures, etc., because we were already making efficiencies and making changes to make us more effective. So all of that hierarchy, all of those people need to be put into the new system, and we are expecting, as a budget holder and manager, I'm expecting that to work for us and for the council for the June position, and we'll be able to go through that with you, and you'll be able to see it in action, which will make a massive difference. And any system that we use now needs to be really functional and working really well. What we have had over the last year is a massive improvement on data, and that will, once that data along with Oracle is being used, so the improvements to our dashboards and our Power BI give us much better tools to be able to manage all of the forecasting, which tells me, so every month I work with, sometimes every week, with our finance colleagues, and we work through the budget to look at the biggest key issues you'll see in that budget are the placements budget. So how much it costs to pay for care, for home care, for care and nursing placements, for daycare, for all of that, the cost of placements, that's where our spend is, and where we really have challenges to be able to get that under control effectively. And that's why you see that's where the growth is. So we monitor the growth against the number of people that will draw on that placement budget. So how many people come in each month into social care? What's the likely level of their cost? And I can tell you off the top of my head that a person with a learning disability, a younger person coming through, is going to have a much higher cost placement than an older person who is going to have a likely nursing placement. That younger person is going to have much more outside activity, education, etc., whereas somebody else will be receiving nursing care. So we look at how much each of those areas is likely to be. How many people do we know about? How old are the people with learning disabilities coming through? What's our mental health demand been over the time? What is Vanessa and CNWL seeing as a demand, and how can we feed that into the model and the system? And each month we're looking at how many people we expect to increase by. What we've actually managed to do over the last 12 months is to get that to a point of knowing the numbers of people we expect to. Pre-COVID, that would have been fairly straightforward. In the last 3 years, that's really changed significantly, and we see this all the time. Now we're able to say from last year, because we've got some really tight systems, we've heavily invested in reablement and rehab, and we're able to stabilise that position of the number of people coming through. But in actual fact, the growth was much higher at the start of our modelling. So 3 months ago, I would have requested the growth has to come from me, saying, so now it's my job to make sure that I don't exceed that growth expenditure. So we've got the budget, we've got the growth, and that should be what we spend this year minus the savings. So that's our challenge, and that's the only reason that we have growth in there, because we don't need growth in staff. We do get some national insurance contribution from government. We need to manage our staff. Contracts all sit within that placement expenditure, and so that's why we've got growth sitting in there.
Thank you. One follow-up.
It's really important follow-up. Could I understand, and it doesn't have to be today, but just when you come back is where the budget transfers are coming from, because I don't understand that column at all. So that would be really, really helpful. And the other thing is that you use the word if there's any slippages going into next year's budget, 2020 budget, but we have been told that we can't afford for that to happen, so therefore that's not an option.
No, indeed.
Right.
It's not an option. Budget is set. If we do have, there will be, as we said, there are risks. We're tackling projects to try and address the expenditure that adult social care have, because it is the highest spending department in the council, and we know that. So we've got to tackle it, and it, not for the faint-hearted. It's going to be a real challenge, but I'm aware that we have to tackle it head on, and if we have some slippage, then we have to find a different way of doing it.
Thank you. Councillor Nelson.
Thank you, Chair. It's just a quick question, and I pick up a bit from what you're saying in regards to that, because it brings in some income, but why are Westminster and Chelsea plus other boroughs impacting on Hillingdon's provision? Can you explain a little bit more about that to us, please?
So in Hillingdon we have a large number of care providers, not Hillingdon owned, but care providers that base themselves here. So they have a home care agency, or they run a care home within our borough, and have done for a number of years. So we have apart from Ealing, I think we have the most care homes within our borough. And the price of care used to be determined by a West London framework, which was run by the WLA, which said you all agree a price for your area determined on the price of property and determined on the price of what they considered to be the fair cost of care. And all boroughs signed up to that they wouldn't go over that price. So if Hillingdon charged, as an example, £1,000 a week for a bed, if Westminster came and said, in Westminster their bed was £1,500 a week, obviously to come to Hillingdon would be cheaper to place their residents. And they actually have very few care services locally in central London. So the agreement set up was, as part of that framework, was that they didn't go over our price. So we had no challenges, because if they placed with us it would be a minimal number of people, because it had to be at their price, so they had to absorb the issue. They couldn't place cheaper here, basically. Now there are all of that framework fell away during COVID, and there is no appetite from care providers to go back to that because of the government's fair cost of care exercise, which increased the rates of care. So our rates of care still remain, and it has to, otherwise we wouldn't be able to manage it, still remain what the local cost should be for a bed that they can place here at a cheaper rate. So they place here. So if they say to the provider, I'll give you an extra £10 a week for that person, the provider will take that out of borough residents, because it's a business, and why wouldn't they? And during COVID, the capacity tracker, which is a national bed base, was set up. It existed before, but it was implemented across all care providers, which means every provider puts on their vacancies and everyone can pull down on them. So for us, that's been really detrimental, because we're an outer London borough with a reduced price base. That means that it's cheaper for others to come here. So more than 50% of the beds in Hillingdon are occupied by people from out of our borough, which is why I have to tackle that in a different way and take a different course of action, which I'll bring to committee next time.
Yeah, super challenging. Councillor Martin.
It's just a quick question, and you may already have answered. You said the difficulties in forecasting pre-COVID and post-COVID, and the demand for adult and child social care has gone up hugely. Is there any modelling or forecasting which will see that go down to the levels that we had before COVID? Because we can't, for the next 50 years, say because of COVID it went up. But will it ever go back down to the level that we saw before?
I think I completely agree. We can't blame COVID for everything, but what we can say is that we know that elective surgery had a 5-year plan 2 years ago to improve, so people that were waiting for surgery during that period of time are still just going through that process. So I think I have seen the stabilising in adult social care last year for the first time in a couple of years. So we're starting to hold a position, maybe tail off, and some of that is due to change in practice and being more efficient and driving that early intervention, and some of that will be that the demand is subsiding and we're getting back to more of the norm. And the more the hospital do for a period of time, the more we'll do, but the more they do, eventually it will get better. So I think we're coming to a point of improvement, but things like technology in care and using different ways of working will make a difference to us, so we'll be able to manage that curve better. Coming out of COVID, that was a real challenge, and probably the year after, so I would say 22, 23, 24 were really challenging years for us. We literally saw it rising like that. The numbers were extraordinary, but that has without a doubt started to stabilise and go down.
Thank you. I think we should end this now because we're going to come back to this in June. I'm looking at the time. But I think that was really interesting. I did feel like we could carry on this discussion for a long time, but obviously... Yeah, go. So, but we will come back with June with some more information and a longer item and an earlier item. And I think, yes, if there can be some sort of specific health and social care budget training for this committee, that would be super useful on top of the major... training that's going on. My voice is going hoarse, which shows you how long this meeting's going on. It's been going on for. But thanks a lot, Sandra and Martin. So you're free to go for now, and we'll see you in June. Yeah, good. Okay, so we've got, where are we? 2 quick items, hopefully. Does anybody have any views on the Cabinet Forward Plan? We're all happy? Okay, fantastic. Work programme. The only thing I wanted to suggest on the work programme is on the past reviews at the bottom, I think the review of Children's Dental Health Service and making the council more autism friendly are things that we could get papers on, and then we could make a decision over email whether we want to have questions on them or not. I don't know if we might do, we might not do, but I don't think we necessarily have to have them as sort of presentations. The CAMS referral pathway review, we should wait until Hillingdon Health Watch have published their report, because that will help us do that. So that might not be until July or maybe even September. But apart from that, I don't have any particular comments. Is everyone happy with that? Obviously, I have to mention that Councillor Cawthorne won't be with us after this meeting. So, I mean, some of us might not be with us either, because who knows? We have the sort of the sort of new municipal year starts. But I hope I'm here, obviously, but I hope everyone else is here, because I enjoy working with everybody. But I know, Councillor Cawthorne, you're going to a higher place, which is to be Mayor of Hillingdon, going around talking to lots of people. So
one doesn't take it for granted. Let's see what happens next week. But no, quite.
No, that is true. That is true. But I think it would be amazing if you didn't go that. So thank you for all your contributions so far, and I'm sure you will be watching us on YouTube from the back of the mayoral car as you're driving around, and maybe emailing us with ideas and questions anyway. So spiritually, you'll be with us completely.
Thank you.
That's okay.
Thank you very much.
Good stuff. So on that note, I think I'll call the meeting to a close.
Okay, so I can ask everybody to remain silent whilst I